Excellency Minister of Health, Madam Regional Director, ladies and gentlemen. Good afternoon from Jakarta. I hope you are doing well amid all the challenging situation during this pandemic. I'm Dewi Sartika as a host for today's webinar, Global and Regional Collaboration for Strengthening Health System Resilience Toward Health Security as part of SEAR National Health Day Commemoration Webinars 2021. This program is collaboration between the Ministry of Health Republic Indonesia, World Health Organization, Association of Southeast Asian Nations, and Institute of Transformative Technology and Policy of COVID-19 Response and Recovery Plan in Southeast Asia. Before we start this program, I would like to thank you for joining us on Zoom, and you can see or access this webinar on Kementerian Kesehatan YouTube channel. For free to interact today's speakers, please type your question into Zoom Q&A box feature, starting write down your name, country or organization, and to whom the question is directed. If you prefer to listening to the discussion in Indonesian, you can activate interpretation feature. Ya, selamat siang Bapak Ibu sekalian. Apabila Anda ingin berinteraksi dengan narasumber, silahkan bergabung melalui link Zoom National Health Day Webinar. Karena di sana Anda dapat menuliskan pertanyaan di kolom Q&A. Tuliskan nama, negara asal atau organisasi, dan pertanyaan ditujukan kepada siapa. Kami sampaikan pula apabila Anda ingin mendengar diskusi ini dalam bahasa Indonesia, silakan aktifkan menu interpretation di aplikasi Zoom Anda. To kick off this event, I would like to welcome Dr. Poonam Ketrapasi, Regional Director, World Health Organization, Southeast Asian Regional Operation, for delivery her remarks.
My warm thanks to the Ministry of Health Republic of Indonesia for inviting me to address this international webinar on strengthening health systems. I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths. In particular, I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths, including in particular, I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths, including 50,000 in particular, I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths, including 50,000 in particular. I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths, including in particular, I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 million deaths, including 50,000 in particular. I first want to commend the government of Indonesia and all Indonesians for their robust response to the Ministry of Health Republic of Indonesia, a pandemic that will soon enter its third year and which globally has caused more than 5.1 75.1 million include 50,000 I first want to commend the government of Indonesia and all countries for their
I would like to welcome Dr. Poonam Ketrapasi, Regional Director, World Health Organization Southeast Asia Operation, for delivering her remarks.
Good morning, and my warm thanks to the Ministry of Health, Republic of Indonesia, for inviting me to address this international webinar on strengthening health system resilience towards health security. I first want to commend the government of Indonesia and all Indonesians for their and my warm thanks to the Ministry of Health, Republic of Indonesia, for inviting me to address this international webinar on strengthening health system resilience towards health security. In particular, I first want to commend the government of Indonesia and all Indonesians for their and my warm thanks to the Ministry of Health, Republic of Indonesia, for inviting me to address this international webinar on strengthening health system resilience towards health security. In particular, I first want to commend the government of Indonesia and all Indonesians for their and my warm thanks to the Ministry of Health, Republic of Indonesia, for inviting me to address this international webinar on strengthening health system resilience. Approximately 50,000 deaths were reported. Though case incidence and death in our region continue to decline, we must not let down our guard. The pandemic is far from over. In addition to accelerated vaccination, countries must continue to implement evidence-informed public health and social measures, which need not be excessively disruptive. Evidence shows that mask use, physical distancing, hand hygiene, and improved ventilation in indoor spaces have a significant impact on viral spread. Alongside these and other measures, contact tracing, quarantine and isolation must continue. Such measures are critical to ensuring localized clusters are rapidly identified and addressed and do not result in larger community transmission. In our region and across the world, we have witnessed the devastating impact of new and more transmissible variants, the Delta variant in particular. To monitor circulating variants and to identify emerging variants of interest and concern, countries must maintain and strengthen coordinated genomic surveillance, a task for which they can be certain of WHO's support. While case numbers in Indonesia and in most countries of the region are at present low, we must use this opportunity to continue to strengthen health emergency preparedness and health system readiness. Specifically, we must identify gaps and share lessons learned, with the overall aim of building health system resilience and achieving full compliance with the international health regulations. I take this opportunity to commend Indonesia for being one of the first countries globally to conduct an interaction review as part of its COVID-19 response. The IAR has since been followed up at 3-month intervals, ensuring each of its recommendations are implemented. I appreciate Indonesia's interest in helping to pilot the Universal Health and Preparedness Review, a member state-led mechanism by which countries voluntarily agree to a regular and transparent peer-to-peer review of their comprehensive national preparedness capacities. I commend Indonesia's active participation in regional WHO meetings, including our recent meeting on identifying and synthesizing the lessons learned from COVID-19, as well as the bi-regional meeting of the Technical Working Group of the Asia-Pacific Strategy for Emerging Diseases and Public Health Emergencies in July. Both globally and in the region, Indonesia's leadership in health and health security is well noted and received. I give my special thanks to Her Excellency Ms. Grata Indah, who has served as co-chair of the Member States Working Group to strengthen WHO preparedness for and response to health emergencies. Countries of the region have been keen participants of the working group, whose activities will inform deliberations at a special session of the World Health Assembly later this month. At the special WHA session, member states will deliberate on a potential new global agreement or international instrument to strengthen health emergency preparedness and response, including possible targeted amendments to strengthen implementation of the IHR. Need it be said, this is a historic opportunity. Next year, Indonesia will assume the G20 presidency, culminating in the G20 summit in Bali in October. The COVID-19 pandemic is expected to be at the top of the agenda, with the prospective theme, Recover Together, Recover Stronger. I'm hopeful that the summit will in all aspects deliver, that it will strengthen global and regional health security, and that it will accelerate progress towards universal health coverage and the health-related sustainable development goals, the focus of a landmark resolution adopted at our 74th Regional Committee meeting in September. I once again thank the Ministry of Health, Republic of Indonesia, reiterate WHO's ongoing and unmitigated support, and wish you an engaging, insightful, and inspiring event. Thank you.
Yeah, thank you so much to Dr. Poonam Khetrapati for the enlightening remarks. Ladies and gentlemen, please join with us today also Bapak Budi Gunadi Sadikin, Minister of Republic of Indonesia, who ready to deliver his opening remarks. Bapak Budi Gunadi Sadikin, platforms, it's yours.
Excellencies, distinguished guests, ladies and gentlemen. As of November 2021, the pandemic has taken more than 5 million lives and affected more than 250 million individuals worldwide. At the same time, the world has invested in $12 trillion to handle it. We should never let this crisis go to waste. As we learn from the current pandemic, we are now in a much better position to collaborate, both at the regional and the global level, to strengthening and making our health system more resilient. Ladies and gentlemen, with great crisis comes great opportunity. And so much it is with COVID-19 pandemic. Each of us has to take our part to strengthen health system resilience securing the coming generations from any crisis we know how to prevent. To deal with the current and to anticipate the future pandemic, we need to rebuild our global health system architecture. As Indonesia holds the next G20 presidency, we take our pride to propose 3 priority issues throughout the G20 presidency. First, we need to build global health system resilience. We need to ensure a mechanism where emergency funding is accessible to all countries so that technical and logistical support can be mobilized when a pandemic emerges. Second, we need to determine and agree on standardized global health protocol. When a health threat is identified, policymakers need guidelines and interoperable information system to respond quickly and effectively. And lastly, we need to advocate product diversification and technology transfer of medical essential countermeasure for production and distributions. When a pandemic emerges in the future, we need to ensure each country has equal access to vaccine, therapeutics, and diagnostic tools. Ladies and gentlemen, in rebuilding our global health system architecture, we need to adhere to the principles of solidarity, accountability, and equity. I'm optimistic that this international webinar will apply those principles through discussions, exchange of experiences, and preparations of collaborative plans. With this, I officially launched this international webinar on global and regional collaborations for strengthening the health system resilience toward health security. Let us not waste any more time and turn this crisis into opportunity. Let us work hand in hand to better prepare our world from any health crisis happening in the future for our future generations. Thank you.
Thank you very much to Bapak Budi Gunadi Sadikin, especially for statement, with the great crisis come the great opportunity. So much it is with COVID-19 pandemic, each of us has to take our part to strengthen the health system resilience. That is exactly we need to hear. Dear participants, as we already know, the COVID-19 pandemic has had unprecedented impact of health, society, and economy globally. This condition is severely testing health system around the world, threatening to damage the global economic and as consequence leading to human costs far beyond the impact of the disease itself. It also has exposed the limitation of many health systems, including some that have been previously classified as high-performing and resilient. How are global and regional collaboration for strengthening health system resilience toward health security implemented? And how is the lesson learned country experiences from COVID-19? Through this webinar, we are aiming to bring the national and international speakers to share experiences and their insight. To provide introduction and also facilitating the discussion on panel 1, I would like to welcome Professor Dr. Adik Wibowo. Professor Adik Wibowo, a medical doctor, obtained her master and doctoral degrees from the United States, full professor at Faculty of Public Health, Universitas Indonesia. She dedicated her work to WHO for almost 15 years in the country. Further, at the WHO Regional Office Cairo, India, then was interested to lead country of Nepal as acting WHO representative and for the country of Myanmar as WHO representative. In 2017, she founded Global Health Initiative Indonesia, which focused on global and international health issues. Ladies and gentlemen, welcome Professor Dr. Adik Wibowo. Good afternoon, Prof.
Good afternoon. Thank you so much for the introduction.
Yes, I offer the station to you.
Okay. Wait a minute. I have my little bit wait. Yes. Good afternoon, ladies and gentlemen. First, allow me to thank the Ministry of Health for honoring me to be the moderator in this August event. The COVID-19 pandemic has an unprecedented impact on health, society, and the economy globally. Learning from COVID-19, key areas that need further improvement for its response includes enhancing response capacities, strong management system, and coordination between the subnational, national, and regional levels. Asia-Pacific region is known as a hotspot for emerging infectious diseases. Therefore, regional collaboration in information sharing, improving capacity for detection and response, and health system resilience for public health emergencies of international concern, or is called PHEIC, is indeed very essential. The Asia-Pacific Strategy for Emerging Diseases and Public Health Emergency, known as APSED, has served as an action framework for the member states in WHO Southeast Asia and Western Pacific regions to implement the 2005 International Health Regulation. This is in line with the global COVID response reported at the World Health Assembly. Ladies and gentlemen, it was further recommended that countries should continue to strengthen core public health capacities, expand strategic operational partnership, such as the Global Outbreak Alert and Response Network, known as GOARN. GOARN is a key component of global health security, and with the partners, GOARN plays very important role in international public health events, such when fighting for Ebola, SARS, and MERS. The health sector in the ASEAN implements many health-related initiatives aimed at responding to the current needs brought by the ongoing COVID-19 pandemic. These initiatives have been sustained, synergized, and scaled up, and form important parts in the ASEAN health sector's health development agenda and work programs. Ladies and gentlemen, one objective of this international webinar is to increase knowledge and awareness. And panel 1, titled COVID-19 Update and Global and Regional Collaboration for Health Security, is there created for the expert to explain more on those above subjects. We have around 2 hours for panel 1. I will invite all distinguished speakers to give their presentations, then followed by the discussion. Meanwhile, listening, dear participants, you may please write your question in the chat box or in the question and answer box. Let me introduce you the first speaker, Dr. Masaya Kato from WHO SEAR, and he will talk about the epidemiological situation and updated COVID-19 scientific brief and SEAR lesson learned for implementation of APSED. Dr. Kato is a public health specialist who have worked with Asian countries to strengthen communicable disease surveillance, preparedness, and response in the past 20 years. She currently works with the WHO Health Emergency Program at WHO Regional Office Southeast Asia and coordinates the team of Health Emergency Information and Risk Assessment. I would like now to invite Dr. Kato. You have approximately 20 minutes and the floor is yours. Thank you, Dr. Kato.
Okay, I hope you can see my screen and I hope you can hear me. Okay. can you hear me?
Yes, we can.
Okay, so let me start. So His Excellency Mr. Budi Gunadi Sadikin, Minister of Health, Dr. Maxilane Randonuf, Directorate General Disease Control and Prevention, Ministry of Health, Dr. Ferdinand Fernando, Assistant Director and Head of Health Division, ASEAN Secretariat, Professor Dr. Eko Supriyanto, University of Malaysia, distinguished colleagues, good afternoon. We sincerely appreciate your invitation for WHO to take part in this important webinar and to deliver this our presentation. So I think this international webinar is taking at the right time. We are seeing the upward trend of the number of the cases reported to WHO in the past 4 weeks. Cumulatively, WHO received over 250 million cases, as well as more than 5.1 million deaths globally. At this moment, we are hearing nearly 500,000 cases daily, as well as more than 6.6 thousand deaths on daily basis. So today in my presentation, I first like to provide epidemiological updates globally and regionally. We also like to provide scientific updates considering potential future scenario of the pandemic. And third, lessons learned from COVID-19 response in the region. We would like to discuss what shall we expect for the future of the pandemic. How can we manage the risks? So looking at this epidemiological trend of the case and deaths in 6 WHO regions, as you see, this Europe is outstanding. Continue to increase, cases and deaths continue to increase in the past recent weeks. The Americas, region of Americas also continue to report relatively high number of the cases and deaths. If we look at the global maps, we see high number of the cases reported mostly in the European regions, shown by very, very dark colors, but also Russian Federation, United States of America. In Asia, we see darker colors from Malaysia and Laos Republic, PDR. And then for the number of the deaths reported globally, we see a little different pictures. Its dark colors are more concentrated in Eastern Europe, Central Asia, as well as the Russian Federation. Here, we are showing the countries with the highest number of the newly reported cases in the last 7 days. And then as you see, the top highest number of the cases are reported from the United States of America, but other 9 countries are from European region. If we look at the number of the case per 1 million population in the past 7 days, or so-called case instance, we see the highest numbers are mainly from the Western Europe, such as Germany, United Kingdom, Netherlands, and then Czech Republic. On the other hand, we see a high death incidence, new deaths per 1 million population in the past 7 days from Russian Federation, but also Eastern Europe, such as Poland, Ukraine, Czech Republic, as well as the United States of America also report relatively high death incidence. Here we brought 3 countries from the Europe, Western Europe, and then the United States, which are facing Delta wave, but also have achieved high vaccination coverage. What we see from the United Kingdom and Germany, we see quite a high number of the cases are reported. But here Germany is seeing a very sharp increase. But the number of the deaths showing orange is having a relatively low number of deaths compared to relative to the reported number of the cases. So with increasing coverage of the vaccination, we see this decoupling of the number of the cases and deaths is being observed. On the other hand, the United States of America, reaching about 70% of the vaccination, about 60% of vaccination is reaching, reporting only high number of the cases, but also high number of the deaths. So let's see who are actually infected and who are actually facing the death or severe diseases. First, for Europe, the highest cases of incidence are reported from the children and the younger adults. The left graph shows entire Europe. COVID-19 case incidence by week and by age group. And as you see, this curve shown in the orange curve, the age group 5 to 14 is reporting the highest case incidence, but followed by those age group from 15 to 49. For United Kingdom, on the right side, the highest case incidence are reported in this age group, school years 7 to 11, and then followed by other younger adults and then children. On the other hand, hospitalization deaths are very much driven by those who are unvaccinated. Left side, this is a situation in Switzerland. We see this not vaccinated, unvaccinated group is reporting highest rate of the severe cases, hospitalization. On the right side, United States America, US CDC reports that the unvaccinated group are driving this number of the deaths. US CDC reports that, that those who are unvaccinated had 11 times, more than 11 times greater risk of dying from COVID-19 compared to fully vaccinated groups. So what is behind the case surge in Europe? There are the combination factors, but including like 99% prevalence of more transmissible Delta variants, relaxation PHSM, public health and social measures in the past, slow or light reintroduction of public health and social measures, low vaccination coverage in Eastern Europe and some of the other countries. Winter is approaching and the people tend to stay indoors longer with a limited ventilation. Healthcare system pressure and increased mortality are higher in presented countries with a lower vaccination uptake, less than 60%. The case surge with a past relaxation of PHSM and possible other factors are also in the country with a higher vaccination coverage. Now moving on to the Asia, this slide shows the epidemiological trend in the region. And then we have seen that India, Nepal, and Maldives experienced a major surge driven by highly transmissible Delta variants around April to May. This was followed by Bangladesh, Indonesia, Myanmar, which experienced the Delta surge in June or July. Malaysia and Thailand experienced peak in August, and it's declining, but they're still reporting a certain level of cases. Singapore is experienced high case incidence at this time, but these are, we understand, mainly driven by those who are not vaccinated. So what is making this Asia having relatively low incidence in many of the Asian countries? One of the reasons is probably growing seroprevalence is providing protection in Southeast Asia region. This slide shows how seroprevalence has grown in different parts of Southeast Asia region. And particularly India has reported a number of seroprevalence surveys. And then quarter by quarter, we are seeing increasing level of seroprevalence. And then particularly, for example, recent seroprevalence survey conducted in Delhi, India, in September reported as high as 90% of people having this antibody against SARS coronavirus 2. And this seroprevalence is primarily contributed by this natural infection, but also, of course, growing contribution from the vaccinations. This slide shows different countries in Southeast Asia region, how much they are making achievement in this vaccination. And then WHO is proposing of the target 40% fully vaccinated by the end of December 2021. And in our region, Bhutan, Maldives, Sri Lanka, Thailand has already achieved this target. but also many countries, including Indonesia, are getting very close to this target. So what is our future scenario, particularly in our region? First, as we saw, growing population from natural infection and the vaccination, immunity are growing, and then this will likely slow down the epidemic, at least temporarily. However, in the context of low transmission, we expect the social mixing may increase, and also immunity may wane. These may lead to the localized clusters and outbreaks in the coming time. But also, in case if new variants who have a high transmissibility or immune escape ability emerges, this might cause another larger surge. So potential determinants of the future trajectory of this pandemic depends on various determinants, including population immunity from natural infection or vaccination. What is the magnitude and what is the duration of this population immunity? Second, level of social mixing and effectiveness of public and social measures. This is another important factors. And then emerging variants, once it appears, that might also create a major increase of the cases. But also therapeutics. We are seeing that encouraging development of the therapeutics. So in the following scientific updates, I would like to touch upon these potential determinants of the pandemic. First, we conducted a modeling analysis for potential vaccination strategies in collaboration with Professor Emma McBride from James Cook University, and then prioritizing vaccination among the older adults and the other higher populations seemingly most effective in minimizing COVID-19 deaths. And as seroprevalence grows, hard protection can be achieved with a lower vaccination coverage, or in other words, in areas with a low seroprevalence, we might need higher vaccination coverage to achieve hard protection. Increased person-to-person contacts or increased social mixing with relaxed PHSM is likely to make it harder to achieve hard protection. And in another word, threshold for hard protection becomes higher. So on the right side, we are comparing this effective reproduction number 4 versus 7. And then if we consider if we can maintain reproduction number around 4, we can achieve hard protection with a vaccination coverage of about 50 to 55%. But if reproduction number is increased by, for example, increased social mixing, we will no longer be able to achieve hard protection, even if we increase vaccination coverage. Looking at the actual situation of vaccination in Indonesia, yes, we have seen major achievement in scaling up vaccination, over 31% as of 17 November 2021. But if we look at the different provinces, we see still variable coverage in vaccination coverage. And also by looking at the different high priority populations, high healthcare workers, other frontline care workers, Indonesia has achieved already very high coverage, but coverage is still limited among elderly population over 60 years of the age. So for Indonesia, one of the important intervention in the coming time, in order to manage future surge, may be to really pay attention on the area with a low vaccination coverage, but also to achieve higher vaccination coverage, particularly among older adults and the other high-risk populations. We talked about the potential increased social mixing might pose additional risks. And then this slide shows the mobility level of the different countries. And then after this Delta surge, almost all countries showing the increasing trend of the mobility. But particularly country like Bangladesh or Nepal is showing the quite high increase of this mobility. Indonesia at this moment is maintaining relatively reasonable level, but still lower than the baseline. But we probably need to be cautious, and then we need to really create a community norm of maintaining good new normal behaviors. So we also would like to understand what is the magnitude and then the duration of the protection from natural infection and vaccination. But starting from natural infections, the literature studies show that the natural infection will give quite robust protection. And then at least for a year, one study reported that 93% of reduced risk of the infection can be provided from these natural infections. And then this is quite a relatively longer follow-up, but the other many studies also reported at least 5 to 7 months, estimated 80 to 9% reduce risks of reinfection in those previously infected. But another thing, important message is that seemingly people aged over 65 seemingly have a reduced protection from the following natural infection. Duration of antibody response in those vaccinated with Pfizer vaccines, seemingly higher initial levels, but much faster decrease compared to those who recovered from natural infections, reaching similar level as a natural infection at the 6 months. Protection against severe disease and death is also another important aspect, because immunity is not just from antibody or humoral response, but also we need to pay attention on these severe disease and death. Vaccine effectiveness against infection and symptomatic diseases seeming to start to decline even in the first couple of months. But the protection against severe disease, hospitalization, and death appear to be maintained even when vaccine efficacy against infection or symptomatic disease are declining, at least the first 5 to 6 months. However, beyond this period, with a longer follow-up, seemingly this protection on severe disease, hospitalization, and death may also start to decline. Vaccination in children is also another important subject that the global community are debating these days. Children and adolescents tend to have a milder disease compared to adults. So unless they are part of the group at the higher risk of the severe COVID-19, it may not be urgent to vaccinate them than older people, those vaccinate them than older adults or those with chronic health conditions and healthcare workers. This is a current WHO and SAGE position. But the evidence is growing, but more needed for WHO and SAGE to make a general recommendations on the use of COVID-19 vaccination in children. But at least Pfizer, BioNTech vaccines, there are more growing evidence, and at this moment, WHO SAGE is recommending that this Pfizer vaccine may be suitable for the use by people aged at 12 or over 12 years old. WHO will update its recommendation when the evidence or epidemiological situation warrants a change in policy. But we also would like to highlight it is very important for children to continue to have a recommended routine childhood vaccines. We talked about the potential risk of the vaccine variants. And then here we would like to first talk about variants of concern and variants of interest. There is, at this moment globally, Delta variant is predominant variants in most parts of the world. And then on the other hand, other VOCs, variants of concern, circulate at a low or very low prevalence. For example, in the past 60 days, based on the dose uploaded to GSAID, more than 99% are Delta variants. And then Gamma 0.1%, Alpha Beta is now less than 0.1%. And then 0.1% comprising of other circulating variants, including Mu or Lambda. But these days, what is attracting attention is a sublineage of Delta variants. And then particularly one example is AY4.2. According to the latest evidence reported from UK and other parts of the world, transmissibility a slowly increasing proportion of cases in the United Kingdom and Europe. And actually, UK reported a small increase in secondary attack rate and in household transmission risks. With regard to the severity, so far no evidence of increased hospitalization or deaths has been reported. With regard to the vaccine effectiveness, no significant reduction in vaccine effectiveness compared to other Delta viruses. At this moment, WHO's risk assessment is that the overall assessed risk is low. But we are also vigilant and monitoring various Delta sublineage. And this slide shows Delta sublineage circulating in selected Asian countries. India and Thailand, it seems like original Delta variants is predominant. But if we look at Sri Lanka, so-called AY28 sublineage is growing sublineage. Indonesia, AY23 is seemingly now predominant as a sublineage of the Delta variants. One slide on the therapeutics. There is encouraging news. Molnupiravir, developed by Merck. According to the press release of the company, it says at the interim analysis, Molnupiravir reduced the risk of hospitalization or death by approximately 50%. WHO has received data from this interim analysis, and then now WHO and then the technical working group is looking into the evidence, whether and how to incorporate into the WHO living guidance. Paxlovid is another antiviral agent developed by Pfizer. And it also, according to the press release, it reduced the risk of hospitalization or death by nearly 90% compared to the placebo group. So these are encouraging results. The full result of the trial is not yet made fully available to WHO, but the evidence to be reviewed for development of the WHO living guidelines. So my last section, I would like to share with you lessons learned based on 2 meetings. Virtual meeting of the bi-regional technical advisory groups, so-called TAG on APSED 3, and then which took place from 27 to 29 July. Another meeting more recently in October, virtual regional meeting, learning from the COVID-19 lessons to strengthen health security and health system resilience in Southeast Asia region. First, leadership and coordination. Almost all countries' speaker pointed out strong public sector leadership is really critical to build and maintain public trust, but to engage and mobilize whole of society and the whole of government arrangement. Clear message on response measure from the highest political leadership is very impactful in guiding public to follow and adhere to public health response measures. Resilient and adaptable health system was also pointed out. Prior investment in primary healthcare was very important and led to more effective response. Reconfiguration of the healthcare institutions to include community-led initiative and task sharing. Flexible and scalable system, including scale-up of designated isolation and treatment centers, networking of public and private sector hospitals. These are considered really critical in responding to the situation. With regard to the workforce, scale up of some of the key public health functions, such as epidemiological investigation, contact tracing, isolation, quarantine was insufficient. Suboptimal utilization of the private sector health workforce was also reported. Therefore, plans and mechanisms to mobilize surge capacities, surge staff, and then particularly using private practitioner using emergency were considered by many of the stakeholders. With regard to the public health measures, contact tracing system to identify high-risk settings is very important. We need to continue to investigate clusters to break and suppress large-scale community transmission chains. And then we have to develop guidelines, strengthen guidance to reduce transmission risk in high-risk contexts. These are particularly pointed out by APSED TAG, as well as risk-based approach for decision-making for proportionate response. Just touch on this point, COVID-19 is known to cause various clusters and super spreading events. Therefore, one of the key strategies to eliminate condition to that favor super spreading, such as avoiding closed space with a poor ventilation, crowding, and then close contact settings. And by identify local settings that are more likely to develop clusters guided by epidemiological analysis of surveillance and contact tracing data. And we might need to develop, strengthen targeted measures, safety guidance, and supervision for those high-risk venues. It might be restaurants, nightclubs, karaoke bars, or many other high-risk venues identified locally. Lessons learned to be
Kato,
continuous.
you have only 1 minute, please.
All right. So let me quickly summarize. So with regard to the information mode, so surveillance, informed decision-making, genomic surveillance is critical. Digital information technology will be very beneficial. Innovative mechanisms to maintain essential health services. With regard to the RCC coordination mechanism across different areas with the partners, listening is also very critical. And then continuous learning, improvement, as RD mentions, after action reviews, interaction reviews. These are really important in making continuous improvement. And this is my last slide with the key messages. Population immunity is growing and scientific progress is made, but still many uncertainties. Like Europe, we might have another surge in the coming days. We need to manage possible outbreaks focusing on key determinants, continue to enhance population immunity through vaccination, ensuring high uptake among older adults and other priority populations. We need to manage local outbreaks effectively before they grow into the larger outbreak through fostering community engagement, community norms, and the risk-based application of public health and social measures. We have to ensure early warning system for timely decision-making and response, paying attention for unusual case surge, hospitalization, and genomic surveillance. We need to learn from the pandemic response for continuous improvement. For example, one of the key lessons, we have to pay attention on whole of society response, emergency preparedness, and then health system resilience. So I would like to acknowledge all my colleagues who contributed to development of this presentation. And then I would like to really thank you for your attention. Thank you very much.
Thank you very much, Dr. Kato, for the detailed information on the epidemiological situation and updated COVID-19 in the region, and particularly also in Indonesia, and what SEAR countries have learned from the efforts in responding to COVID-19. Thank you once again. Allow me to invite the second valuable speaker is Mr. James P. Katampongan from the Asean Secretariat, and will share with us on strengthening ASEAN regional health security recovery through regional cooperation. He is currently Senior Officer of the Health Division, a part of the ASEAN Socio-Cultural Community Development, ASCCD. Under his purview is the facilitation, coordination, management, and implementation of the ASEAN Health Development Agenda focused on health priorities, such as responding to hazards and emerging threats, strengthening health system, healthy lifestyle, and also ensuring food safety. He has engaged with the International Federation of Red Cross and Red Crescent Societies and with the Philippine Red Cross before joining the ASEAN Secretariat in 2016. Mr. Katampongan, you have approximately 20 minutes, 23 minutes, and the time is yours. Please.
Thank you, Professor Wibowo. Good afternoon, everyone. First of all, allow me to express the gratitude of the ASEAN Secretariat for inviting to be part of this National Health Day International webinar that focuses on strengthening health system resilience towards health security. Can I request the committee to upload the presentation? Thank you. So before I proceed, allow me to also thank Professor Wibubo, our esteemed speakers for this panel discussion. First, apologies to from Dr. Ferdinand Fernando, as there's an urgent meeting that he has to attend to as we speak. Actually, he's with the Ministry of Health of Indonesia, accompanying the Secretary General of ASEAN, as well as the Deputy Secretary General for the ASEAN Socio-Cultural Community, to discuss COVID-related matters with the Minister of Health of Indonesia. So in the next 20 minutes, allow me to share what the ASEAN health sector has been undertaking in order to strengthen the ASEAN regional health security, which is a key component or one of the major areas of the ASEAN health sector's strategic plan, particularly through the ASEAN post-2015 health development agenda. Professor Wibubo mentioned earlier that the ASEAN health sector has many initiatives and programs in strengthening health resilience towards health security. And indeed, there had been initiatives even before the pandemic. The ASEAN health sector had been undertaking those for almost a decade. And those initiatives had been utilized as well as expanded and sustained when the pandemic really evolved and affected the region. And as we are also looking at how to move on as part of a recovery, we will also share what the ASEAN health sector had been doing together with the other sectors of ASEAN, as well as its development and dialogue partners. Next slide, please. So this presentation will have 3 parts. We will start with what the ASEAN health sector had been doing as part of its investment to contribute to strengthening health security in the region. And then we'll move on to what have been the initiatives and response of the ASEAN health sector when COVID-19 evolved, and what are the programs which the ASEAN health sector is currently undertaking in order to respond to COVID-19, as well as strengthen the public health emergency preparedness and response of the region as part of the recovery program of the ASEAN. These initiatives had been really rolled out through the leadership of Indonesia, which is the chair of the senior officials for health development, as well as the ASEAN Health Ministers meeting. Next slide, please. So before us is the illustration of the ASEAN post-2015 health development agenda, which is the strategic plan of the ASEAN health sector that contributes to the ASEAN vision, as well as the ASEAN socio-cultural community blueprint, which is its roadmap for 10 years. So we have a roadmap of 2016 to 2025. The AFDA, as we call it, was developed based on looking at what had been the global and regional frameworks related to health, the ASEAN declarations, as well as what are the different areas that the health sector has to look into. So we are also looking at climate change, disaster risk reduction, and contributing also to the regional frameworks related to the Asia-Pacific strategy for emerging diseases and public health emergencies. So on the basis of this referencing, the AFDA had been developed with a vision, mission, the goals and strategies, and look at what are the strategic health priorities that the health sector has to look into in the 10-year time frame, and develop work programs to really implement programs and projects that contribute to the realization of the vision and mission, and as well as goals and strategies. So this AFDA, or the agenda, contribute to the ASEAN vision and the mission, as well as the broader sustainable development goals. Next slide, please. So just briefly on the vision and mission of the ASEAN health sector. So the vision is a healthy, caring, and sustainable ASEAN community. And the mission summarizes what are the major areas that the ASEAN health sector would like to work on. So we have areas in promoting healthy lifestyle, responding to all hazards and emerging threats, strengthening health systems and access to care, and ensuring food safety. For this presentation, we will focus on responding to all hazards and emerging threats, which is very relevant for the subject matter. There are goals under those broad or major areas, and particularly for responding to all hazards and emerging threats, there are 3 goals that are related to strengthening resilient health systems, also enhancing the regional preparedness and response capacities for public health emergencies as well as disasters, and also to look into environmental health threats and other hazards that affect the region. Next slide, please. So under those broad areas, the ASEAN health sector has identified strategic health priorities, which they will be focusing on during the time frame of the roadmap to 2025. So under responding to all hazards and emerging threats, there are 6 priorities now. During the period 2016 to 2020, there were only 5 health priorities. But with the evolution of COVID-19 and the response that had been poured into the COVID-19, the ASEAN health sector has agreed to include another health priority on regional preparedness and response to public health emergencies. Really to consolidate what had been done and achieved, and still to further improve what are the challenges and gaps in regional health security, as well as preparedness and response to public health emergencies. Just to mention also that while the focus of responding to all hazards and emerging threats are towards really preparedness and response, there are also major areas or health clusters that contribute to strengthening health security. So for example, in strengthening health systems, they also contribute to through pharmaceutical development, human resources for health development, as well as a digital health and health information system. Certainly in ensuring food safety, there are also initiatives that contribute to strengthening health security. And for promoting healthy lifestyle, we're talking about nutrition in emergencies, mental health emergencies, wherein they have also those initiatives. So all of these initiatives are being coordinated by the cluster on responding to all hazards and emerging threats. Next slide, please. So the next slides will focus on initiatives pre-pandemic that were aimed to really strengthening health security. So one is the Mitigation of Biological Threats program. This was started in 2014 as part of the first phase to 2018. And the second phase has been from 2019 to 2022. This is done in cooperation with the Canada's Global Partnership Program, or now the Weapons Threats Reduction Program. So when you look at the different components under the MBT program, there are initiatives related to public health emergency preparedness and response, and that's through the ASEAN Emergency Operations Center Network for Public Health Emergencies. We have also disease surveillance, laboratory strengthening, risk assessment, and risk communications. So these are a number of project activities which are being implemented by the ASEAN member states in cooperation with Canada and a number of partners at the country and regional levels. Next slide, please. So another initiative is this project for strengthening ASEAN regional capacity in disaster health management. This is at the moment, a pre-disaster, focusing on responding to the health impacts of disasters in the context of ASEAN. But with the evolution of COVID-19 and then looking at the reflecting on the experience on Ebola, the project is also looking at how they can also contribute to responding or preparing for and responding to public health emergencies. So this is a development or an effort to strengthen emergency medical teams at national and regional levels, guided by the WHO EMT initiative, as well as linking these initiatives with ASEAN disaster management mechanisms, which is being coordinated by the ASEAN Coordinating Center for Humanitarian Assistance and Disaster Management, or AHA Center, which is being hosted by Indonesia. So the different components relate to strengthening coordination within the health sector, within ASEAN, as well as with partners. Strengthening networking and response mechanisms through the conduct of regional collaboration drills, the development of tools for regional collaboration, the conduct of regional trainings, the development of standard training modules to strengthen national disaster health management capacities. As well as academic networking within ASEAN, as well as outside of ASEAN, including the development or the setting up of an institute for disaster health management. So as we speak, they are completing the first phase, and starting 2022, this initiative will start the second phase until 2026. Next slide, please. So broadly, those are the initiatives in strengthening health security under the purview of responding to all hazards and emerging threats. We will move on to what the ASEAN health sector did as part of response to COVID-19. Next slide, please. So as soon as the ASEAN health sector, through the ASEAN Secretariat, received the first reports of unexplained pneumonia clusters in Wuhan through the senior officials for health development of China, the ASEAN Secretariat, guided by the SOMISD chair, immediately circulated information to ASEAN member states, including Japan and Korea, using the ASEAN +3 SOMISD or health cooperation mechanism. So that started the regional response, which also was followed by the mobilization of existing mechanisms of the ASEAN health sector based on the initiatives of responding to hazards and emerging threats, and with the support of the MBT program. So one of the mechanisms that was quickly mobilized was the ASEAN EOC network, which facilitated the sharing of situation updates, the technical exchanges, and real-time exchanges using email as well as mobile media platforms. The ASEAN health sector also initiated preparedness and response practices sharing, including discussions on the challenges, the gaps, and needs. And then this was these were done through health webinars, by the ASEAN EOC network, as well as the other ASEAN health cooperation mechanisms. So circulation has been done through the website, the ASEAN website on COVID-19, the ASEAN +3 and the health cluster on the responding to all hazards and emerging threats. One of the initiatives under the MDT program is on strengthening big data analytics and risk assessment. So that's through the ASEAN Biodiaspora Virtual Center, which started in February 2020, the issuance of thrice weekly reports on the risk for transmission of COVID-19. And that has continued until to date. Which provides what's the situation in different countries in terms of the cases, the deaths, as well as vaccination status, as well as what are the potential for reopening and recovery. So knowledge exchange, technical information sharing was also done by other networks within the ASEAN health sector. So we're looking at the ASEAN +3 Field Epidemiology Training Network, the Public Health Laboratories Network, as well as the Biosafety and Biosecurity Network. Indeed, the COVID-19 is a global, unprecedented public health issue, which required collaboration and cooperation of various partners. So the ASEAN health sector has also undertaken that, not only with the existing partners, but also new partners. So we're talking about exchanges with the United States, with France, with Italy, in terms of what had been their experience, and then what the ASEAN member states can take from in terms of really getting up their response mechanisms. Risk assessment and risk communication was also part of the priority areas due to infodemic. So the ASEAN health sector has also mobilized the Risk Assessment Risk Communication Center, which is under the purview or a component of the ASEAN EOC network for public health emergencies. Next slide, please. So this is a busy slide, but what we are just trying to highlight here, that on the left, those are the initiatives that were undertaken by the ASEAN health sector before the pandemic happened. And with the evolution of the pandemic and in cooperation with dialogue and development partners, new initiatives have been proposed and had been taken on by the ASEAN health sector. So the middle box are those initiatives that are initiated and led by the ASEAN health sector. And then the one on the right are ASEAN-wide initiatives which the ASEAN health sector had been significantly contributing. So the following slides will also try to elaborate those, particularly those highlighted initiatives. Next slide, please. So we'll start with the box on the right. So in terms of looking at the ASEAN-wide response, so under the supervision and leadership of the ASEAN Coordinating Council Working Group for Public Health Emergencies, which is an inter-pillar cross-community initiative to coordinate the initiatives and the response of sectors under the ASEAN Political Security, ASEAN Economic Community, as well as the ASEAN Socio-Cultural Community. So these are the ASEAN-wide initiatives that are led by them, but with strong support from the ASEAN health sector. One is the creation of the COVID-19 ASEAN Response Fund, which is a pool of resources which ASEAN member states as well as partners contribute to support detection, control, and prevention of COVID-19 through the procurement of medical supplies and equipment for response, as well as to support cooperation in research and development, including technical support, sharing of best practices, and capacity building. As we speak, the procurement of additional vaccines for ASEAN member states have been processed with the hope that during the first quarter of 2022, those will be already delivered to ASEAN member states. So the ASEAN is now again looking at how the other resources, contributions from the ASEAN member states and partners will be utilized, looking at what are the gaps and the challenges at the moment, and then how this fund can support. Next slide, please. So in addition to funds, we are also, particularly during the first stages or months of the pandemic, there were really shortages of medical supplies from personal protective equipment and so on. So the ASEAN has also come up with this regional reserve of medical supplies. These are earmarked materials and supplies which will be made available by ASEAN member states to other member states that are in need of these medical supplies. So these are based on the WHO list on critical supplies for COVID-19. The list has been circulated for member states to really identify what are those critical supplies that they can contribute and then make available and ship to other member states when in need. So it's some sort of a virtual warehouse. There's no physical warehouse at regional level that is being established, but there are mechanisms for quick deployment, delivery, if there's a request from the ASEAN member state. Next slide, please. Another initiative has been the the development of the ASEAN strategic framework for public health emergencies. So this is the core document that will guide the ASEAN in enhancing preparedness response as well as resilience to public health emergencies. So this has been already endorsed or adopted by ASEAN leaders last year. So the ASEAN, through the reference sectors and particularly the ASEAN health sector, is utilizing this framework for the development of more detailed and more comprehensive plans for preparedness and response to public health emergencies. So this, as the ASEAN really promotes a multi-sectoral preparedness and response, so this is also consistent with the One Health approach that is also promoted globally. Next slide, please. So 1 year on in responding to COVID-19, the ASEAN health ministers conducted a follow-up special video conference to state back on what has been done and achieved by the ASEAN health sector, what are the existing challenges, priorities, and gaps, and how the ASEAN health sector can continue to collaborate, work in really responding to COVID-19. So the result of that special video conference, which was chaired by Indonesia in July 2021, resulted to the issuance of a joint statement, which are listed. The priorities of which are listed on the screen or on the slide. So it. The ASEAN health ministers agree to enhance laboratory capacity and particularly reinforcing genomic surveillance to be able to swiftly detect and share information of potential variants, to foster greater understanding and implementation of health protocols in the adaptation of the new normal, as well as to further avert misinformation and fake news. To guide ongoing ASEAN health initiatives, particularly the establishment of the ASEAN Center for Public Health Emergencies and Emerging Diseases, which is equal to regional centers for disease control, as well as the development of the structure and framework for the ASEAN Public Health Emergency coordination system. Also to provide guidance and support in the vaccine rollout across ASEAN, and then to support the operationalization of the ASEAN Comprehensive Recovery Framework, particularly under priority enhancing health system as part of ASEAN's exit strategy from this COVID-19. So I have a few more slides.
Okay, 1 more minute, please.
1 more minute.
Yes.
Apologies. There are still a number of slides which relates to vaccine security and self-reliance on the ASEAN Public Health Emergency Coordination System, as well as the ASEAN Center for Public Health Emergencies and Emerging Diseases. Anyway, the slides will be available to participants. But can we move on to slide number 21? If I have a minute.
Yes, please.
Yeah, just wish to conclude that the ASEAN health sector continues to be committed to further strengthen ASEAN's regional health security, building on the recent programming guided by the ASEAN post-2015 Health Development Agenda and the experience on COVID-19. So as we discuss, the goal, the strategy, and the health priority of the ASEAN post-2015 Health Development Agenda has been updated, and particularly the preparedness and response to public health emergencies have been incorporated in the agenda. The ASEAN health sector will also continue to harness regional cooperation within the sector, within ASEAN, as well as with partners in the implementation of pandemic recovery and in further pursuing the broader health development priorities based on the 21 health priorities that we have mentioned. And based on the guiding principle of the ASEAN health sector, which is whole of government, whole of society, maximizing synergies and partnerships, definitely the further strengthening of health security will be together with other sectors as well as with other partners. So with that, thank you for the attention. I was not able to show some of the other slides, but we have an open discussion segment wherein we may be able to share more information on the other initiatives. So thank you very much.
Thank you, Mr. Jem Katampungan, to share with us on how ASEAN strengthened the regional health security, on its initiatives, what and how ASEAN respond to hazards and emerging threats. We learned also about the Health Development Agenda 2021-2025 with 6 priority areas, including also initiative to respond to capacity and strengthening teams in the countries on disaster management, strengthening collaboration and networking with academics, and strengthening health security. There are a lot of information that you have shared with us, but I'm so sorry that the time doesn't allow us to go beyond. Further, you also gave detail on preparedness and response to COVID-19 since early 2020, including discussion on challenges and needs, circulations of information using websites, and strengthening big data on risk assessment. We can follow later, continue the discussion in the discussion part. Thank you very much once again. The third valuable speaker is Mr. Patrick Anthony Drury from WHO headquarters, and his presentation is on the GOARN and operational partnerships. Mr. Drury works at the WHO as the manager of the GOARN since the year 2000. Also, currently as the Deputy Incident Manager of the WHO COVID-19 Global Pandemic Response. In his position, he runs the Operational Support Team, OST, and operation of the network in support to WHO major epidemic and humanitarian emergencies. In the past, Mr. Drury worked with the permanent representation of Ireland to the European Union. Mr. Drury, I invite you to the floor, please.
Thank you very much, Professor Addick. Thanks also to Jim and to Messiah for those very informative presentations and updates. I'll speak to you about the Global Outbreak Alert and Response Network. But before I start, I would like to thank the Ministry of Health Indonesia, the WHO country office in Jakarta, and colleagues at the regional office for Southeast Asia. And also to thank the Indonesian healthcare workers and experts that have been part of the response there. The pandemic is a really terrible event for families, communities, but also for the health workers that have been under incredible stress and pressure for so long. So our thoughts and solidarity, I think, are with them first and foremost. Thanks for the opportunity to come to talk. It's my objective in this is really to try to, it's a bit of an information session and to encourage collaboration and engagement with colleagues in Indonesia and across ASEAN. As Jim has set out there, there's a lot of activities being led within the region, and at the global level, we can learn a lot from initiatives and activities that happen at national and regional level. So please, if I could have the presentation. Thank you. Next slide. So epidemics and pandemics are not new events, and WHO has been dealing with them since its inception. But at the end of the last century, there was wide recognition that, one, the international health regulations were not fit for purpose in an increasingly connected world, and that information and disease traveled far more quickly around the world. So in 2000, WHO and a group of what we would have considered at the time all of the key partners in GOARN in outbreak response, which was 70 institutions, came together in Geneva and agreed to set up a network. Since then, that network has grown to 260 technical institutions and networks, and through that network reaches out to over 500 partners worldwide. I think what we have to recognize, though, is that as we work our way painfully through the pandemic, there are far more partners that we need to engage with in preparedness, in readiness, and in response. The objective of the setting up the network 20 years ago, and it continues to be what partners want, is to ensure that we're able to provide technical support to countries, primarily for outbreak response, and that's best achieved through close coordination between the institutions and the governments involved, and the rapid deployment of multidisciplinary technical assistance when it's requested. Next slide, please. The partners all agreed that we needed this network 20 years ago to assist countries by ensuring rapid multidisciplinary technical support for outbreak response, by strengthening coordination and among partners, and particularly when we're deploying international expertise to provide advice. And also, it was recognized that, as we heard, epidemics and pandemics are unique learning opportunities, and we have a huge responsibility to those, particularly who lose their lives, to learn and get better at what we do as we go forward. Next slide, please. The network is supported, has two main elements that supports its functioning. One is a 21-member ESCOM, Strategic Advisory Group, which provides the strategic direction and governance for the network. And the second is an operational support team at WHO, which coordinates partners' involvements in alert and acute response missions, supports network development and activities, and special projects, some of which I'll talk about later, and maintains daily communications about acute events happening around the world. That operational support team is now also supported by secondments and staff that come from some of the other GOARN partners. Thank you. The steering committee, I just wanted to put up the list of names there. From the Southeast Asian region and the Western Pacific, we have a number of important partners on the steering committee, not least Professor Dale Fisher, who will be talking later in the second panel discussion. Thank you. This steering committee provides a lot of much more support now than was originally envisaged, and it really has taken on a strong role in the governance of the network. Thanks. Next slide, please. So over the past 21 years, what have the network partners and the experts in those partners achieved? We've had over 3,500 individual deployments of experts to support countries. And that would cover every major epidemic, I think, that has taken place over that 20-year period. In the case of Indonesia, we had a couple of particularly important events where the network provided support, not least the Indian Ocean tsunami, but also to support the investigation of early bird flu outbreaks back in, I think it was 2004, 2005. That's translated into over 100,000 person hours in the field, providing support to over 100 countries worldwide. There have been 170 major outbreaks and missions that we've been supporting. That capacity, it's important to recognize, comes primarily, well, exclusively from the partner institutions. And I think as we move forward, we really need to see how, on the one hand, we can engage more institutions, but on the second hand, how we can support advocacy and work which helps invest in the capacity of those institutions. Thank you. Next slide, please. This is just to show you the breadth of the deployments over that period of time and the countries around the world that have been supported and involved in the outbreak response activities of the network. Excuse me. Across the bottom, you can see that there are a number of peaks. The initial period of the network was very much about responding to major outbreaks of Ebola and other emerging diseases in Africa. Then there was a period when it was mainly influenza, avian influenza, and other respiratory diseases. Excuse me. The pandemic of 2009, 2010, the influenza H1N1 pandemic. The two high points relate to the major Ebola outbreak in West Africa. And since then, the network has been primarily responding to the continuing Ebola outbreaks in Central Africa, and over the past year, almost 2 years now, to the COVID-19 pandemic. This just represents those who've been deployed, particularly for the COVID pandemic. All GOARN partners have been fully, if not 200%, involved domestically in responding to the outbreaks. The breakdown of deployments, as you can see, that inverted pyramid in the bottom right-hand corner, will give you an idea of the type of support that we're identifying through the network. That's not to say that that would remain the type of support that needs to be deployed, because, as we know, countries are investing heavily in developing their IHR core capacities, and that translates into additional laboratory support, additional epidemiologic support, in particular through FETP programs and others. Next slide, please. This is a snapshot of the overview of the pandemic response and the ongoing operations for GOARN. That's almost 240 experts from partners have been deployed to the field. The vast majority of those have been for COVID response. we're beginning now to identify expertise from the network to deploy to support the scale-up of vaccine operations, which will be the major focus, I think, for the next 3 to 6 months. And while COVID has dominated the public health agenda globally, there have been major outbreaks or additional outbreaks of Ebola in Guinea and currently in DRC, where we've been providing support. Thank you. Next. In addition, as part of the pandemic response, partner coordination has been much more a core part of what we've been doing beyond the deployment of people to the field. Since the very beginning of January last year, major GOARN partners were embedded in the COVID-19 Global Incident Management Team at WHO headquarters. And we've had weekly virtual teleconferences with all of the partners providing detailed updates on COVID-19 and other outbreaks around the world to strengthen operational coordination, to ensure that we're able to align on how different agencies are assessing risk and to share information on response, both at the national level and what partners were contributing internationally. This has been supported by the weekly teleconference, but also by a knowledge platform where we share information and support the networking among the partners. Next slide, please. Also, during that period of time, our steering committee has taken on a more significant role and contribution in governance of the network and in providing support on priorities and input into strategic planning at the global level with WHO. We have formal meetings of the steering committee every 6 months, but operational meetings initially throughout last year took place every month and are now taking place every 2 or 3 months as we get through the pandemic, hopefully. The primary objective of the steering committee at the moment is to look at all of the COVID reviews and panels that have been put in place, and also the outcomes of the 2 World Health Assemblies which will take place this year. One took place last May, and I think as you heard from Dr. Poonam Singh later this week, there will be the second and a special meeting of the World Health Assembly to look at the current state of the pandemic and how to build new systems going forward. All of those reviews and panels have recognized the contribution that partners, operational partners and technical partners make in all aspects of outbreak response and pandemic response. As a result, we're working with the steering committee and partners to develop a strategy for the further development of the network and its operations in the coming years. And the steering committee members and many network partners are already engaged in discussing how the network can make that contribution to global health security. A key part of that is to review various aspects of regional development of the network, to look at the response operations and what's different now in the pandemic time than in previous times. I think it's clear that there's a significant shift in where capacity is in the world and where it's recognized. And we need to change how we operate and work to reflect that many countries now have significantly more capacity and have learned a lot from the pandemic. Thanks. Next. I think the advice that we've received from member states and from those in the panels and discussions has been to mobilize the experience and voice of the network, to advocate for networking science and solidarity. That's important because at the moment, international technical collaboration and work between institutions is under severe stress, and there are major challenges in confidence in science. So that's one of the things for the network going forward, which is a key part of what we need to do. The other thing that we need to improve is our involvement and working directly with communities. We need to build on the experience in countries and regionally about the critical role of community confidence in advice and in outbreak response interventions. Without that community confidence, we simply cannot control the outbreaks. The steering committee has identified a number of priorities, and in the current global context, which is about looking at a review of the global systems. I think we heard this from the minister at the beginning. A review of the global systems, a change in the investment a change in the pattern of investment, so that national agencies, non-governmental agencies, academic institutions that are providing key support in response are funded to be able to do that. And I think we've got renewed interest and pressure on the network to be more precise in how we can work with partners to strengthen preparedness and readiness as we go forward. Next, please. So the priority of the network and what we want to be able to identify new partners and work at a country, regional and global level are in these areas, in the areas of alert and risk assessment. I think we all recognize that improved coordination of information, and the earlier information is shared, the better the opportunities for response. To build public health rapid response capacity by a number of specific initiatives, strengthening integrated outbreak analytics, strengthening the deployment of rapid mobile laboratory support, and strengthening how we work in risk communications and community engagement. All of this is supported by a training program, which relies very heavily on GOARN partners. I'll come back to that. Please, next slide. So the next couple of slides are going to go through some of the key developments, and many of these have been triggered and taken forward at a regional level. There's wide recognition that being able to provide rapid mobile laboratory support is a key part in the earliest possible investigation of an outbreak. WHO and GOARN partners have been working over the past 3 or 4 years to develop a conceptual framework for this rapid response mobile laboratory idea. And it's based on 4 pillars: leadership and coordination, standardization, monitoring and evaluation, and workforce development. It's led by WHO Euro with the European GOARN partners, and they've got to a point of agreement on minimal operating standards for the laboratories as a partner-driven initiative. This is supported by a series of increasingly complex simulation exercises throughout 2001 and 2002. Those exercises start with tabletop exercise, move on to operational based drills, and a series of field exercises, which will culminate next year in almost a global Olympics of mobile laboratory support. We hope to be able to build on this regional initiative and engage laboratory partners in other regions to further endorse the standards that have been agreed, and to further develop the coordination mechanisms and the agreements that we have in place, so that we have more laboratory support to deploy internationally, but that we also support the development of that laboratory capacity at a national level. That is, I think, particularly important in very, very large countries and those that have a federal system of states and different entities. Thanks very much. Next slide, please. I think from the beginning of the pandemic, there's been a renewed interest and commitment on putting the community at the center of the outbreak response. Actually, it comes a little before the pandemic, because I think this has been most painfully learned by WHO and partners and the communities in Eastern DRC during the major Ebola outbreaks there. There is a new initiative called the Collective Service for Risk Communications and Community Engagement that involves the Red Cross, UNICEF, WHO, and GOARN as a network at the core of the collective service. Next slide, please. And then it reaches out to additional partners across the network and beyond to build the risk communication and community engagement capacity. This is a new way of working for GOARN, because we've got 3 of the major partners at the center of it. The challenge for us is to ensure that we're able to mobilize the full support of the network in this area with those 3 partners at the center. Thank you. Next. Also, learning from Ebola in DRC and other outbreaks, there is a new initiative within GOARN. This again comes from greater involvement of key partners in the network: WHO, UNICEF, US CDC, EPSED, which is connected to Médecins Sans Frontières, the Institute of Tropical Medicine in Antwerp, and the London School of Hygiene and Tropical Medicine are the core group that have been working in Ebola in DRC for several years now, and have come up with a holistic approach to integrating operational data, epidemiology, social science, and program data. In many ways, this is not new, because that is the core of having that information is how you make decisions at the cold front of response. I think the challenge for us is to take this integrated outbreak analytics, make sure that it's further strengthened with a risk communications, community engagement attitude and activities, and that will really help us at a national level and internationally respond better to outbreaks quicker. Thank you. Next. Over the 20 years the network has been going, data management and data sharing have been a key part of the challenge of outbreak response. And where it works well, it's also a major building block of effective and strong outbreak response. So we've brought together within GOARN a network of technical institutions and partners that have helped develop GoData, which is a data collection tool for outbreak investigations and response in the field. It's primarily about contact follow-up and the visualizations of chains of transmission. It's designed for the outbreak responder in the field, and the data and the system is owned by the national authorities. This is coordinated with WHO and GOARN. And as you can see in the map there, there's, I think, 80 projects in 60 countries around the world where this tool is being used. We have a major scale-up in implementation and development planned for the next 2 years, and we're really looking for countries with which we can work and partners with whom and with which we can also engage as this tool is rolled out more comprehensively. It will be a corporate endorsed tool of WHO. Thanks. Next. So these different elements are what we've learned from recent outbreak responses and the pandemic. And in the pandemic, the major learning lesson at a national level has been you're on your own to an extent, right? The challenges of moving around the planet were very severe for the first year of the pandemic, and even now it still remains a challenge. So I think there needs to be an investment in resilient health systems that are able to take bigger stresses and bigger responses, and mobilize bigger responses, and to redefine how we mobilize and support that national capacity from a global network. We're working now on strengthening in-country outbreak alert and response capacity with GOARN partners. The Ministry of Health has a primary responsibility of this, and government, but how can we create additional elastic in the system to be able to respond very rapidly?
Mr. Drury, 2 more minutes, please.
2 more minutes. Thank you very much. We really would like to work with Indonesian colleagues to see how we can further strengthen the systems that you already have, how we can share experience that we've had over the most recent years, and see how we could ensure that the international support that's available within the bi-region and globally is available and can be mobilized as easily as possible, which is never easy in a crisis. Next, please. So this is, and again, this is a request for interest from partners and institutions in Indonesia who are online. All of these activities are supported by a training program and a network of training partners. The training is multifaceted, multi-layered. There's an entry level, which is mainly online, mainly electronic. There's a tier 2, which is outbreak response scenario-based field training. We conducted one of those field trainings in Baristagi in Indonesia in 2012. Would really look forward to coming back and doing more training and learning from Indonesian experts. And then at the high end, we're developing outbreak response leadership training and online gaming. I'd like to wrap up now by letting you know there's a global meeting of our partners in December 2021. That's an online event, because while we could probably have a number of partners from the global north come to Geneva because of the level of vaccine and the protection people have, there is a fundamental question of equity and fairness. As we couldn't have many of our partners and many friends from the global south, we've decided to keep this as almost exclusively an online meeting. It will be led by the steering committee and set out the strategy for the development and operation of the network over the coming years. And we would encourage partners and those who are interested to please get in touch and participate in this. Thank you. Next slide. Just to say thank you very much, and it's a real honor to have been invited here and to join this panel. Thank you.
Thank you very much, Mr. Drury, for sharing the information about GOARN from its inception to what is on till today. Thank you very much. Ladies and gentlemen, we have been enlightened by the 3 distinguished speakers, and now we come to the discussion session. I think I will have with me questions compiled by the organizing team from the chat or question and answer box. So allow me to read those. Let me go to that particular question. Question and answer number 1 is from Dr. Imran to Dr. Kato. You mentioned about the importance of primary healthcare. Could you explain more about that, Dr. Kato, please?
Thank you very much. So should we answer one by one? Let me try to answer these very important questions. Many countries probably had some level of a primary healthcare system with a community engagement. But when this pandemic hit, and then when country has started making the response, this primary healthcare system seemingly made a major difference. For example, let me first share this example of Thailand. Thailand had like 1 million village healthcare workers. And then these village healthcare workers really worked closely with the disease control department with regard to the many response, surveillance and response activities. And then this included like contact tracing, but also following up and then providing support who are under quarantine. And then it seemed like overall these community systems, village healthcare workers, really made an important contribution in this COVID-19 surveillance as well as response. But we know that this was not just made ad hoc. Thailand invested past 40 years of developing these community mechanism of the village healthcare workers and then closely connected to the primary healthcare facilities. Therefore, this is one of the examples, but I know Indonesia also has a very strong primary healthcare systems connected to the communities. We saw similar example from Bangladesh, India. Many examples are here, which I probably cannot explain everything today. But what is very clear is that the investment from the peacetime in this primary healthcare system, creating, enabling, and supporting the policy environment, how we can strengthen this community mechanism. I think this is one of the very important lessons learned from this COVID-19 pandemic. Thank you very much.
Thank you very much, Dr. Kato. I haven't seen another or other questions, but I would like to share that question also to the other two distinguished speakers. If you also want to give the response on the primary healthcare, because primary healthcare is everywhere. I would like maybe Dr. Jeb, Mr. Jeb to respond, and also Mr. Drury to give the response on primary healthcare. Let me read again the question. You mentioned about the importance of primary healthcare. Could the speakers explain more about that, especially in relation to the COVID response? Please.
Yeah, thank you, Professor Wibu. With regards to primary health care, that's very critical that our communities are really geared towards being able to promote health as well as to respond to if there are increased cases of infections and particularly emerging diseases. That's critical in the context of that's where these cases, these issues happen. So that's why we need to allocate and further promote the strengthening of primary health care, which is a very important element in the health system of a country. So while at the national level, the focus has been on policies and strategies, it's in the community where these policies and strategies are being operationalized, and that's where that's why it's very critical that we allocate resources in terms of financing, but also really ensuring that we have sufficient and qualified health workers on the ground, so that if there will be new cases of infectious diseases, they can be addressed and treated immediately. And particularly if we have infectious disease specialists at the ground level, we will be able to quickly detect those potential cases that may further expand, not only within the community, but also other communities. So within the context of the ASEAN health sector, while the work has been at the regional initiatives, there's really conscious awareness that while we support member states in strengthening the health system, that the primary healthcare level also be supported. So at the regional level, there may be no direct initiatives, but through information sharing, knowledge sharing of the experiences of member states on how they strengthen primary health care as part of the health system. That's how the ASEAN health sector contributes to that aspect.
Yes.
Over to you.
Thank you very much, Mr. Jem. Now, Mr. Drury, you have any comments on the question?
Thanks very much, Professor Adik. I'd agree fully with what Masaya and Jim have said. So rather than repeat that, perhaps I would add that I think the challenges to coming from WHO headquarters to make our technical guidance more accessible and more relevant to the primary providers of healthcare to communities. We've learned a lot about how difficult it is to communicate and during the pandemic, and that's the same in every other outbreak. And I think really empowering, and that's investment, training, staffing, but also a devolved responsibility for the primary health providers is a key part of it. But you can't do that and not give them the tools. And the tools are really to be able to communicate effectively so that they can work with local communities to get high take-up of whatever, in this case, public health and social measures are being advised, as well as providing the primary care for people. Thank you. And I think it's this is a global crisis, and the core learning from this is the same in Indonesia as it is in where I'm sitting at the moment in France, or in DRC in Africa, or in Bolivia in South America. Thank you.
Thank you. I haven't gotten any other question from the organizer, but let me also use the time because we have still 5 minutes left. Mr. Drury, you mentioned about the main outcomes of the pandemic reviews for GOARN includes mobilizing experience and voice for advocating network. So I would like to ask to all three presenters, how do you do the networking, enhancing networking in the countries, especially in the SEAR region? And what are the issues when you are advocating about networking? I would like to get the answers from the three presenters. Mr. Drury.
Thanks very much, Adik. So I think in my slides, there's one statistic, which is that there have been 3,500 people deployed to the field over the past 20 years. And that these are people who've gone to SARS-1, to Ebola, to yellow fever, to cholera, to meningitis, to dengue, to pandemic flu, to COVID-19. And I think that's a unique experience, particularly with the colleagues that they worked with at a national level. There are international panels. There's a World Health Assembly meeting next week. There's leadership at a political level and at a technical level can have a voice to give advice and make suggestions about what new global systems should be like. I think our responsibility is as a network to reach out to those who've been deployed to the field and those institutions and get their advice on what do they see as what they need. And I think that would give incredible authority and power to messages which might come out of it. I think that's the key part of the networking. That community of responders involves a multidisciplinary dimension as well. These are infection control experts, field epidemiologists, laboratory scientists, social scientists, risk communicators. And we know that the effective outbreak response and this is amplified in the pandemic, is when you can get all of those technical institutions, technical disciplines working together in harmony and in close coordination. So that's our responsibility at the moment. Yeah. I hope that answers your question. Thank you.
Thank you, Mr. Drury. I have to intervene with another question. Another question posed this is this is to Mr. Jim. What are the priority infectious diseases in the ASEAN region? What are the priority infectious diseases in the ASEAN region? Mr.
Yeah, thank you, Professor. Thank you for that question. The ASEAN health sector is guided, as we mentioned earlier, by the ASEAN Post-2015 Health Development Agenda, and particularly under Cluster 2, which I mentioned earlier, the ASEAN health sector has identified five specific or five priority diseases that it intends to focus on. One is in relation to HIV and AIDS prevention and control. The second is on rabies elimination. Third, on lymphatic filariasis elimination. We have also dengue prevention and control. I think so those are the priority diseases which the ASEAN health sector is addressing. Certainly, there are other infectious diseases which the ASEAN member states are putting priority, but at the regional level in the ASEAN, those are the priority. Sorry, I failed to mention tuberculosis as the fifth. And certainly, under the same cluster, cluster 2, certainly emerging infectious diseases is a priority. That's why we have these mechanisms, quick response preparedness mechanisms in order to prepare the region for those eventuality. Over.
Thank you very much, Mr. Katampongan. We still have, I think, for one more question. If there are other questions posted in the chat or in the question and answer, I would like to receive that. Let me wait for a while for another question, perhaps, from the audience and participants. Okay, if there is none so far, ladies and gentlemen, now we come to the end of panel 1. Allow me to convey my high appreciation to the valuable, distinguished speakers, where we know more about what's happening in the region, what's happening in the global arena, what's happening in the ASEAN, especially to respond to pandemic COVID-19. Thank you very much for Dr. Masaya Kato, for Mr. Jim Katampongan, for Mr. Patrick Drury, for sharing your knowledge, expertise to us, and also thank you very much to all participants for your active contributions. And now I will say this is the end of the panel 1, and I now give the floor back to the Master of Ceremony. Wassalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh. Thank you, Professor Adik, for the great facilitation of the first session at this webinar. Now, let us move to session 2. For the second session, I would like to welcome Associate Professor Wan Rudy Isarnawatachai, PhD. She is a program leader and senior researcher of the Health Intervention and Technology Assessment Program, HITAP, which is a semi-autonomous research institute of Thailand, Ministry of Public Health in Bangkok, Thailand. She is also an associate professor at the Institute of Health Policy, Management and Evaluation, University of Toronto in Canada. She also has contributed to the training on health technology assessment to support universal health coverage and health system in Asia, Africa, and North America. Ladies and gentlemen, welcome Associate Professor Isanuatachai, PhD. Associate Professor Isanuatachai, the screen is yours.
Thank you, Ms. Devi. First, I would like to echo the gratitude to the organizing committee for putting together this platform for all of us to connect. It has been a very insightful discussion moderated by Professor Adik, and I hope I can continue the discussion. And wish, if you have seen our distinguished speaker list for panel 2, it will not be a difficult task because we have a great lineup for all of you this afternoon. Now, we have heard about the COVID-19 update, the situation, the vaccination status. We have heard about the ASEAN efforts on many different health development agenda, including this important and crucial network to support in the time of public health emergency. Now, to build on that, if we were to reflect for just a couple of seconds, COVID-19 has shown us many things. It has shown us how small the world really is, how connected all of us are, and how we are truly stronger together, which align nicely with the theme for this panel too, which is on the technical topics and country experience. Now, we can learn so much from each other. You may have heard about some of the work that's been happening in Thailand, including the COVID-19 Multimodal Comparison Consortium, which include modelers from across the world, including World Bank, USAID, WHO, the Center for Global Development, for example. Our early HTA health technology assessment work of COVID-19 vaccine are also in collaboration with our partner in Kenya, Philippines, Singapore, among many other groups. And last but not least, the current work on vaccine certificate, where Indonesia has been a wonderful member who is part of the working group and also the policy working group as well. So these are just examples that how we can learn from each other as we are in this time of COVID-19 pandemic together. Now, it's often easy to say, let's collaborate, but I think today mark another great example of how we can truly walk the talk. The upcoming presentation will share country experience in the time of COVID-19 and leave us with the lesson learned. I am excited, very excited, and I hope all of you are as well. So for our first speakers, without further ado, please allow me to get right into the first presentation, which will be Dr. Imran Pambudi. Dr. Imran is the Deputy Director of the Health Quarantine at the Ministry of Health in Indonesia. He was involved in several essential health programs at the ministry, including the National TB Program, Maternal Health Program, and was also a Deputy Director of the Multilateral Health Cooperation Department. In this panel too, the presentation will title Indonesia Health System Resilient Toward Health Security, Lesson Learned from COVID-19. Please help me welcome Dr. Imran. Dr. Imran, the floor is yours.
Yeah, Captain Prof. Pambudi. Yeah, good afternoon, everybody from Jakarta. So thanks for the introduction me about the important topics for this one. So I want to show you about how Indonesia can coping the COVID pandemic in this year. Next, please. Yeah, next. Slide, please. Can you give the slide, please? Yeah. So our country, Indonesia, has 34 provinces, 516 districts, over 17,000 islands, and over 273.5 million citizens. It's spread over 1.9 million kilometers square land area. And also we have 35 international airports, 135 international ports, and 10 land cross-border. So you can imagine how big Indonesia is. Slide, please. We can see Indonesia's COVID-19 cases and vaccination updated as of November 19. There is 347 new cases accumulating to 4.2 million cases, and over 217 million vaccine doses are administered, with the 85.7 million are fully vaccinated. And this is shown that we are monitoring these indicators every day, and we show it, and we put it in our social media, so everybody can monitor and can see how the progress of the vaccination and the COVID-19 program, health program about that one. Next. So until 16th of November 2021, Indonesia has a cumulative 4.2 million COVID-19 cases and 143,000 COVID-19 deaths since its first case on March 2nd in 2020. As seen on this graph, since then, Indonesia has faced, and shall we say, pass through two waves of COVID-19 cases and deaths. The first wave hit and reached its peak on early 2021, and the second wave reached its peak on July 2021. And the second wave hit Indonesia really hard, with a record of over 50,000 cases a day and over 2,000 deaths a day, and a positive rate of over 30%. And Indonesia became Asia's COVID-19 epicenter. Slide, please. On COVID-19 deaths, Indonesia has a cumulative of 143,000 COVID deaths. Here we can see there are two waves on the trend, same as new cases trend, and the first wave hit and reached its peak on early 2021, and second wave reached its peak on July 2021. Next, please. Further latest update for Indonesia, we had rate of 1.04 confirmed case per 100,000 residents, and 0.56 positivity rate, and 1.14 deaths per 100,000 residents. So it means that the progress is very good, and now Indonesia is also shown that it's very low, and we can see the presentation from the Dr. Kato that Indonesia, the color of Indonesia is what we call not blue, not dark anymore. Slide, please. Now we compare Indonesia COVID-19 situation that's during the peak of the second wave that hits on July, and the latest situation on November 2021. So we can see here how is the difference of the situation in that period. Slide, please. So based on the comparison before, now we ask, how did Indonesia manage to face and handle that second wave? The answer is a restriction, which Indonesia got a score of 71.7 on how strict the policies are. And we hit score of 71.7 during May until October 2021. That is when the second wave hits. There is an easing to this restriction. So our score went to 57.58. So we can see the COVID-19 Stringley Index, which measures government responses through policies regarding school closures, travel bans, and so on. It also includes the COVID-19 containment on health response. So currently, we are still facing the COVID-19 pandemics. And from the graph above, it can be seen the curve of the epidemic of cases in Indonesia. The hope is that we can flatten the epidemic curve to match the target for handling the pandemic. And to achieve this, we need the right strategy. With the aim of flattening the curve, the government of Indonesia continues to take measurable steps to stop the spread of the virus and minimize its social and economic impact on society. Next, please. So this is the specific measures regarding COVID-19 that's taken in Indonesia. So we divide the strategies into 4. So we improve the detection, therapeutic care, vaccination, and behavioral changes. Slide, please. Government developed several task forces to tackle COVID-19 problems. Oxygen task force is one of the important things to reduce death. Ensuring sufficient oxygen supply is the key to reduce mortality. There is oxygen task in every province to solve their problem. We switched industrial oxygen to medical oxygen during May until August 2021. And also, the community empowerment is also important to ensure health protocols are taken by people and provide social support to the family which suffer from COVID-19, include help them to find oxygen and medication for self-treat patients and help patients to find ICU for severe cases. Next. Strengthening is mainly carried out on 2 pillars, namely surveillance and prevention of transmission. The strategy requires the government and the community to work together in dealing with the COVID-19 pandemics. The government is obliged to do 3T, while the community is obliged to do 3M. This testing is being carried out by government so that more people can know their risk status for COVID-19. Strengthening is done by increasing the capacity of the laboratory by adding laboratory networks, providing reagents, as well as adding and increasing the capacity of its human resources through training and workshop. Furthermore, trace or case tracking so that more people who are likely to be exposed can be found faster and quarantined. For contact tracing, it will be strengthened by utilizing the digital tracing, which will be combined with conventional contact tracing so that tracking can be started faster. Next, please. Indonesia's government implement the community activities restriction enforcement to prevent and deal with the surge of COVID-19 cases and deaths. We call it in Indonesia PPKM Darurat. It is urgently reinforced on July 2021, as the number of cases and deaths are surging and indicating the second wave in Indonesia. Indicators for categorizing of district during that restriction are transmission level, response capacity, and also the pandemic situation. So for the response capacity, testing, tracing, and treatment capacity, which reflect on weekly positivity rate and number of close contact per number of new cases and also a bed occupancy ratio. Slide, please. Indonesia government implemented community activities restriction enforcement to prevent and deal with surge of COVID-19 cases and deaths. So the key point of this policy is activities restriction based on sectors. You can see here in Indonesia, for non-essential factor, we put it 100% conducted by work from home system. For essential sector, work from office system is allowed. For example, maximum 50%, and strict health protocols. But for the critical sector, work from office is allowed 100% with strict health protocols. Teaching and learning activities are carried out 100% from home. Supermarkets, traditional markets, grocery stores are open with specifically curfew and maximum capacity of 50%. And temporary closing of shopping centers, malls, trade centers are during this period. Next, please. So COVID-19 vaccination program in Indonesia started in January 2021 with its first phase prioritizing to the health workforce. Second phase of the vaccination added elders and government and civil servants its target population. And the third phase of vaccination added general public that has higher risk because of their geospatial, social, and also economic characteristics. Vaccine receiver originally were only population that is aged 18 years old and over. But since July 2021, population aged 12 until 17 years old are also eligible as more vaccines are available in Indonesia. And there are 10 vaccine brands that are approved in Indonesia. However, only 5 of them are more common to use. We print it in the red font. Next, please. So I will also introduce Peduli Lindungi. Peduli Lindungi is an Indonesia contact tracking application that is integrated with the users Indonesia resident numbers, or ID numbers, and includes quite a lot of features like vaccine certificate, COVID-19 test result, electronic health alert card, as tracking users for long distance traveling history, and also we can see here about the get vaccine to allow users to schedule vaccination. And nowadays, the vaccine certificate feature used as part of reinforcing community activities restriction, because we want all of the citizens that eligible in Indonesia get vaccine, because we know and we believe that vaccination can prevent deaths and prevent the severe cases for the COVID. I think that's all, Prof. Manudi, about my presentation, and time get back to you. Thank you.
Thank you very much, Dr. Imran. That was very informative. I think I learned a lot about Indonesia from your presentation. I always know that Indonesia is a big country, but seeing the statistic you shown, the number of ports, the number of airports, and really to see how successful Indonesia has been in managing the second wave, it has been truly inspiring, even role model for other countries as well. So thank you. So I think we do have time, but if it's okay, maybe we'll continue with the next presentation, and we can have the discussion period, longer discussion period toward the end. So if anyone have any question for Dr. Imran, please feel free to send those questions in, or as we will have a period of time where we can ask those questions to the speaker later on. Okay. So for the next speaker, to continue the discussion about learning from country experience, I would like to introduce the next speaker, who is Professor Dr. Eko. Dr. Eko is the General Chairman for the Institute for Transformative Technology and Policy for Supporting Implementation of COVID-19, or ITTP COVID, which is very cool acronym. He is also a professor at the School of Biomedical Engineering and Health Sciences at the University of Technology in Malaysia. He is a president of Indonesia Association of Hospital Engineering. His research interests include a number of exciting emerging new areas: healthcare management, artificial intelligence, medical informatics, and electromagnetic. Dr. Eko will share his experience on the topic of public health protocol and technology to enhance cross-border interconnectivity for international travel and trade, a topic which I think many people are very excited and interested in this right now. So please help me welcome Dr. Eko.
Okay, thanks. Okay, Prof. Wanrud for the nice introduction of me. Okay, can I share my screen? Yes, all right. I have it. Yes. So one more, thank you for moderator, okay, Prof. Wanrudi, okay, for introducing me, okay, to this webinar. And I would like also to thank to Mr. Imran and also Ministry of Health Indonesia for inviting me, and also ITP COVID member to share our research findings on public health protocols and technology to enhance cross-border interconnectivity for international travel and trade. This is my topic for my presentation today. So my talk today is extracted from previous ITTP webinar. This is on the travel certificate, on the tourism zoning, digital certificate, or digital security, and also guideline for living together with COVID that we have done, okay, since a year. So my talk will start with the introducing problem and objective of our research. Then I will share our comparison study and latest research finding related to the health measure. Next, I will share the proposed health protocol and cost risk benefit analysis. And the end, I will discuss the regulatory requirement and also conclude my presentations. So I think it is well known that COVID-19 causes decreases of international tourism arrival from UNCTAD. Okay, we see that up to 74% worldwide. Okay, and this really affect to the million job loss. The COVID-19 also decreased international trade. Even worse, okay, we see here compared to the economic crisis in 2009. Those situations caused by implementation of cross-border health measures include lockdown in many countries. According to Lee et al., from the Journal of Globalization and Health 2021, there are some health measures implemented to control travel and trade related to the movement. These include, for example, here screening, testing, and quarantine. These two big areas, which is screening, testing, and also quarantine, are very powerful parameters to control the cross-border movement. This, however, I think we need to evaluate due to the implementation of vaccinations. So, but there are some issues with these health measures basically that we will try to explore. First is the quarantine issues. The quarantine is actually costly mental effect to the people waiting too long alone at home or any place for the isolations, and also decrease productivity. According to the Kaiser Family Foundation survey also, the isolation make 58% having the health mental issue, and then 30% said affected to the ability to do their job, and so on. The next problem, what we explore also, the nasal or oral swabs, RT-PCR, which is also not comfortable, high cost, and takes many times or many hours to obtain the result. To tune this situation, we have conducted a research to evaluate the both parameters or the health measure, which is effectiveness of quarantine and also COVID-19 screening. Basically, our research goal is to have the cross-border health protocol, which is comfortable for traveler, very low cost, and protecting privacy, but also protect public health security and support economy recovery. So we conduct survey across Southeast Asia populations, and our findings show that, for example, here, people want to have the ASEAN Smart Mobile Certificate. 92% agree to have it. So far, so that people need to have better cross-border health protocol and technology. It means currently implemented is good, only need to have better. For example, for traveler, they don't want to have the quarantine basically. If a quarantine, then it's very minimum. Especially for very low cost, for very low risk traveler or negative COVID-19. And the traveler want to have also low cost and comfortable rapid testing. For example, saliva, AI-based screening, electronic nose. And also traveler also want to have the just minimum data input, not too many. And with high security data protection and private data is protected. And for public health community, based on our survey, we need to have also the health protocol, which is not producing infections from and also transmit to cross-border traveler. And the traveler's data is monitored, action can be executed immediately, people accept the public health protocol, and people and regional health are protected, and not very, very important is also support the economy recovery. I think this is the survey that people want to have it. Our study is based on few health measures implemented prior or pre-border, prior to traveling, and then on arrival or at the border and within the destinations. This include, for example, here in the study of the vaccination effectiveness, screening or testing, and quarantine. So if we compare the existing health protocol from 5 countries, include here Indonesia, Thailand, Malaysia, Singapore, and I just took one from Europe, Germany. Our results show that most of countries show that the vaccination means the people need to show the vaccination certificate. Only the vaccination is not to be used for the stopping people to do the cross-border traveling. They still allow only required quarantine and so on. And then all countries have their own mobile apps to control the movement of the people. And then another result also, the all country also ask travelers to conduct here the real-time PCR or rapid test antigen prior to the departures. For example, here Indonesia need to have 27 hours, Thailand also 27 hours, Malaysia 27 hours, 72 hours, sorry. Real-time PCR, and then Singapore, less is 2 days or 48 hours, and then Germany, either RT or the rapid test antigen 48 hours before or 28 hours before, or PCR within 27 hours, 72 hours. So this is for the test prior to departure, and then in the destinations, Indonesia also required to have during the first day, and then 3rd day or 4th day of quarantine, for example. And then Thailand also need to have on arrival. Malaysia also we have also option RT-PCR, RT-K antigens, and in Singapore we have, and Germany now required basically. So and then the other thing is on the quarantine. If we see here, Indonesia required quarantine for 3 days for full vaccinated and 5 days for first dose. And then Thailand, for the vaccinated, is not required for quarantine for a certain area, for example. Malaysia, still required 7 days. And then Singapore self-isolated until negative PCR, and Germany also self-isolated. So all 5 days, when test negative. This is the existing protocol. And then here we see some mobile apps that available in Southeast Asia, all countries having it. Include, for example, Peduli Lindungi Indonesia, and then Thailand Plus in Thailand, and then Mitigation in Malaysia, and so on. From here, from our study, we found that vaccine is not entry requirement, but strongly requested. Most countries having mobile apps for COVID-19 risk management, and then 72 hours real-time PCR testing is applied to most countries. Some countries, however, allow to have 24 to 48 hours antigen rapid test. And then most countries apply quarantine for international traveler, but the trend is less days and self-quarantine. So the next, I would like to share our study on the effectiveness of the COVID-19 test, vaccine, and quarantine. The question are whether we need to have really nasal or oral swabs, very not comfort RT-PCR, or we just need to have saliva antigen rapid test. The question whether, okay, we really need to have the vaccine certificate, I mean, the certificate maybe yes, okay, but vaccinated to enter the region or really not. And then whether we need to have the quarantine or, okay, not. So I think this is the question that, okay, I will try to answer. Study from Malit that published in BMC Medicine 2020 so the effectiveness of RT-PCR varies with the time, basically. The detection rate between 0 and 4 days here is, for this onset, is around 89%. And then decrease become 54% after 10 to 14 days. So it means here the real-time PCR result is time dependent. From the study also shown that the real-time PCR is still able to detect the infections even after 30 days here. But the detection rate is just less than 20%, basically. This study also agreed by the Halliwell, so that the RT-PCR result, the highest detection rate was achieved before 5 days of onset, basically. And then, Sarah Churita, so that the COVID-19 test result will be also affected by the location of swab. They have 3 types of location, which is in nose, nasal, and then oral, oropharyngeal, and also from the saliva collected. Sorry. Here, the result. Use the nasal swab, for example, the detection rate within 5 days is from 40 to 100%. And then use the oral, for example, here is 32 to 100%. And using saliva is 87 to 33 to 92%. So within 7 days. And then after that, decrease 33% after day 20, and then here 40% after day 5, and so on. So it means the detection is really location dependent. And then other study from Domenico so that the saliva antigen rapid test has sensitivity of 100%, if you see here, and specificity of 94.2%. Comparing with RT-PCR, saliva antigen rapid test basically has higher detection rate compared to RT-PCR. This is from the new saliva rapid test antigen. So and then another study from LaGuardia from MIT so that evidence that the cough sounds and AI can have can become the low-cost screening method with sensitivity of 98.5% and specificity of 94.2%. So this shows that RT-PCR detection rate depend on time, day after onset and swab location. The detection rate also vary from 32 until 100. And here, the saliva antigen rapid test has been recommended to be used for COVID-19 rapid test due to sensitivity, which is 100%, specificity 94%, detection rate higher than real-time PCR, comfortable, higher comfort compared to NPS and OPS, and the cost is just 10% or even lower than RT-PCR. The next study is on the vaccine effectiveness. SARA, if we see in the Lancet, volume 398, so that the effectiveness of vaccine after 4-month vaccination, again, the Delta variants, the effectiveness is less than 60%. And other variant, including Alpha, is less than 70%. So if we do linear regression, it is found that effectiveness of vaccine might be, only around 1 year, if we see here. Again, Delta is maybe just 9 months. To the other variant is 13 months. It's around 1 year. But however, this need to have the further research. We need to wait. Study from Reimers show that the vaccinated and not vaccinated people having the similar viral load. If we see here, this show the vaccinated people still having risk to carry the infection to the healthy people. The effectiveness of vaccine, as was studied in Canada, they found that unvaccinated people have 10 times higher. I think the previous speaker confirmed with this 6 to 11 compared to vaccinated people. From our study, it is concluded that vaccine is effective in decreasing COVID-19 patient hospitalization and death. Effectiveness of vaccine, however, decreased along the time. After 12 months, vaccine effectiveness can be less than 30%. People with fully vaccinated are not 100% immune against COVID-19 infections. And then vaccines shall not be used as travel requirement due to the possible infections, but requirement for travelers that have high risk for hospitalization and death. So the next study will be on the effectiveness of quarantine. Wells et al. Found that the probability of the virus transmission is close to 0 after 14 days quarantine, and 9% here for 3 days quarantine. So based on some research finding, we calculate the effectiveness of quarantine, 0, 3, 8, and 14 to death rate for several scenarios, including negative and positive COVID-19 people to vaccinated or non-vaccinated people. So for example here, the probability of death rate of 0 days, if we only apply 0 days quarantine of negative COVID traveler to vaccinated people, is only 0.74 over 100K populations. The next one, for example, the probability of death rate of 8 days quarantine of negative COVID traveler to non-vaccinated people is around 0.74 also of 100K here. And then, next one, the probability of death rate of 8 days quarantine of positive COVID traveler to vaccinated people is around 0.7 of 100K populations. And then the probability of the death rates of 14 days quarantine of positive COVID traveler to non-vaccinated people is around 3 of 100K population. If we compare the result with the death rate due to the seasonal influenza, this is between 0.75 to 4.25 for people under 65 years old, we can see here that risk 0 days quarantine for non-infected COVID-19 traveler in vaccinated region is lower even compared with the risk of seasonal influenza. It means no meaning if we do quarantine for the people that already tested and non-infected and in the vaccinated regions. This is basically the message that I want to share. So quarantine is not required for negative COVID-19 traveler in vaccinated region. 3 days quarantine is required for positive COVID-19 traveler in vaccinated region. 8 days quarantine is required for positive COVID-19 traveler in non-vaccinated region. So from study of quarantine effectiveness, we can conclude that quarantine for 8 to 14 days is required to protect non-vaccinated people due to the high-risk traveler. Quarantine for 3 days is required to protect non-vaccinated people due to high-risk traveler and to protect vaccinated people due to low-risk traveler. No quarantine is recommended to protect vaccinated people due to low-risk traveler. It is important, however, to monitor the traveler 14 days history of COVID-19 risk for deciding the duration of the quarantine. So from the latest research finding, we summarize that vaccine certificate is recommended but shall not be used or not become the compulsory requirement for international travel due to vaccine effectiveness decreases a long time and lower asymptomatic condition for vaccinated people. Low cost, high detection rate, comfortable test methods shall be applied to detect traveler COVID-19 infections. For example, here saliva antigen rapid test or AI-based rapid test is recommended to be used. okay, 3 times, 7 to 5 days before or prior traveling, 1 day before, and then on day of the traveling, whether before or okay after arrival, and every day in the destination. This method is much more better compared to only 1 time PCR or 2 time PCR. And then quarantine is not required for negative COVID-19 traveler on the last 3 measurement time, 5th, 1st, and okay 0 days. Mobile apps shall be used to monitor health risk of traveler 14 days prior to traveling and during traveling in the high-risk destination. Here is the proposed health protocol. Basically, okay, from our research, we have basis to develop the health protocol. We include, for example, prior traveling, we see the healthy lifestyle, okay, the implementation of 3M, the planning of the traveling. But okay, we consider also to avoid the PCR and then quarantine. Quarantine is for low risk, not required. Compulsory for PCR is not required, and then but okay, vaccine is always okay recommended. So here, for example, we need to fill up the health declaration form during the traveling provided by mobile apps. Okay, 5 times, and then conduct rapid test screening just using okay saliva at home, for example, 1, 2, 3 before traveling and every 3 days, and then we need to okay include in the mobile phone, and then mobile phone tracker need to be activated. Basically 14 days before and during the traveling when in high risk zone. So okay, here we can okay apply the behavior or 3M risk calculator, health risk calculator, location tracker, and then we need to apply the digital vaccine certificate, rapid test tester, and then okay risk detector based on the okay chip methods, and also okay at the destination we need to apply location tracker and then behavior and health risk calculator. If we have this, basically the our method is we can apply okay like this. Basically we can apply on the day -14 before traveling until okay the day end of the traveling or at the destinations. We need to have the traveling plans, and then we need to have the online tracker. We need to apply the 3M. We need to use to apply the COVID-19 rapid scan or rapid test. So and then okay we need to have the PCR test if found it for example positive, and then quarantine not required except if found it also PCR positive. So and then if we compare with the existing health protocol with that previously I already explained. So we have the vaccine certificate is optional, health insurance is optional, COVID-19 travel app is a must, and then health risk assessment we need to do 14 days and then 4 times prior the traveling, and then before the departure we need to have also 3 times saliva test, rapid test, and then the destination also we need to have tests, but also using the cheaper and comfortable methods, and then quarantine is no for negative and then yes for positive. This is the purpose. So if we conduct the cost, risk, and benefit analysis, we found, this is C, cost, risk, and benefit, we found here that our proposed having the highest benefit of cost and risk, basically 516. And we apply the same method to Indonesia, current Indonesian, Thailand, Malaysia, Singapore, and Germany. The second one measure is 446 by Germany, continue by Malaysia, and so on. So So in order to implement the proposed method, regulation is required. And this includes the data exchange and interoperability, and then privacy protection and data security, recognition of the COVID-19 rapid test method, recognition of the health risk assessment method, recognition of the COVID-19 risk destination, or for example, we need to also make the similar criteria for the unit risk assessment, and also recognition of behavior risk assessment method. So basically the regulatory requirement that need to be agreed by most of the country that want to apply this method. So for my final talk, from our study, we conclude that first, the current health protocol is really need to be optimized in order to accelerate the economy recovery due to COVID while maintaining public health security. It's very clear. Second, quarantine and RT-PCR tests shall be applied only for the high-risk traveler. And then we need to use the digital technology, but digital technology with the considering data interoperability, cybersecurity, and private data protection is required to implement high quality public health protocol. Last but not least, but this is a requirement. Cross-country regulatory requirement shall be discussed soon. Today, hopefully, is the first discussion that we have, and then soon need to be decided and then implemented. Thank you very much for your attention. I give back to Prof. Wan Rudy to continue the sessions.
Thank you so much, Professor Eko. Wow, that was a very, very informative, insightful presentation. Learned a lot. I think that if not, we didn't just get information about Indonesia, we also learned about other countries as well, which I find that to be very, very helpful. And the question that you address include many that I think a lot of people have in mind, like, PCR versus the antigen rapid test, the different type of vaccine. I am going to save my questions and just to ask for your advice in the discussion period. But thank you. So before I introduce the next speakers, I would like to remind everyone that we do have time for discussion period right after the next presentation. So please prepare those questions. You can also start sending them in the Q&A box, and the organizer will put them and ensure that the speaker get that. Now, our final speakers bring with him many years of experience. So his bio itself is very fascinating. So please allow me to actually share the detail. And I can see Professor Dale there already. So Professor Dale Fisher is an Australian infectious disease physician who first moved to Singapore in March 2003 during the SEAR outbreak. I still remember that I was in Canada at that time. Now he has many leadership roles in the international outbreak mission, including the chair of the steering committee for the WHO Global Outbreak Alert and Response Network. Now in Singapore, he is the group chief of medicine at the National University Health System and lead many efforts for the Ministry of Health, including chairing the National Infection Prevention and Control Committee. Additionally, he supported many WHO guideline efforts and was one of the 12 international technical experts who visited China in February 2020 to investigate the COVID-19 outbreak. So without further ado, please help me welcome Professor Dale Fisher. Professor Dale.
Thanks, Wan Rudy. Can I assume I'm on full screen and I've got good audio?
I can hear you clearly and I can see your screen as well.
So I am presenting from my hotel room in Geneva. So sometimes the connection's not so good. So if you're ever doing that, then I might turn. So firstly, thanks for inviting me along. I look forward to the day when these meetings are face to face. But I thought to meet the brief of what was asked of me, which is more about recovery, it is important to go back a few steps, because obviously the degree of recovery for any country will depend a lot on how the pandemic affected that country. And I want to be reminded that an outbreak is not all about response. It involves preparedness, readiness, and as we've said, recovery afterwards and reviewing how everything went. There's always a lot of focus on the response, but preparedness and readiness are key to that. So I just wanted to show a few things that I guess helped Singapore be in good stead. Well, since I can remember, but certainly since 2003, there's been a lot of emphasis placed on pandemic preparedness. We still only ranked about 17th in this checklist of countries and assessing their pandemic preparedness before the pandemic. Of course, US was ranked number 1 and UK was ranked number 2. So that probably reflects that the checklist there's more to it in reality. Anyway, we've done a lot with infrastructure in terms of isolation and quarantining capacity, surge capacity, attention to settings of the underprivileged, although this could have been better, attention to various settings where you could anticipate spread taking place. Human resources, there's been a lot of recruitment, I guess, including myself, arguably, but a lot of development of infectious disease talent in the country, a lot of pandemic preparedness exercise. We do annual simulations in each hospital. We've had an Infectious Disease Act in place for decades. And of course, many countries are still grappling with what are the actual laws of the country. Can you actually legally shut down businesses and legally demand people have tests and quarantine? Leadership and coordination, we built the National Centre for Infectious Diseases, which was complete in 2014. And all these sort of other things, the various surge plans for all the various pillars of outbreak response, a lot of stockpiling of drugs, PPE. I even had we've always got 3 or 4 months stockpile of food because Singapore doesn't make most of its food, obviously. And I even had stockpiles of cash, which might sound like a money laundering exercise, but that was an announcement early on in the outbreak that they can support people whose businesses have to close. And of course, mask fitting, you still see this being grappled with in many countries, but we have these exercises regularly. So just a word on infrastructure. When building a hospital or when renovating a hospital, there is a whole vocabulary, if you like, in this field. It's a whole field that many don't even understand it exists. So expandability, are there actually places in key areas where you can put up another makeshift building, for instance, next to the emergency department? And in Singapore, you see lots of these sort of empty spaces where you can expand or develop either in the long term, if you want to grow your hospital, or even in the short term if you're having a major outbreak. Convertibility, so these are places where maybe there are open spaces in the hospital, maybe there's all the furniture can be easily moved, so you can convert areas to other places. And then there's adaptability. You might have intensive care units, but are your high dependency units the same? Can they be adapted to become ICUs? And even in our isolation wards, these can also be converted to intensive care units if need be. So this is about getting all the fittings in place, the dialysis, the oxygen, all these things need to be in place. So there is a little bit of a science behind developing infrastructure for a pandemic response. And this was a big empty area right next to our emergency department, so you could see we could easily erect a new tent. We published on this, and we're able to within 3 or 4 days erect a building which has been there through most of the pandemic. It's about an extra 20 or more isolation assessment cubicles. And all hospitals were able to erect such places to expand the infrastructure. It got a bit hot, so in Singapore style, overnight this huge tarpaulin was put on to create shade, and that made the whole area much more livable. Also, we've got a lot of isolation areas really built over the last decade. Even our car parks can be converted, so these have been featured, and these have all got toilets and showers easily implemented. This is one of those shell spaces where you can move all the furniture and then put up petitions to create overflow space. Large open areas, so you can do visitor management, and visitor management. All these are in place anyway across all of Singapore's hospitals, so you have to register and you can't get in until you've registered and got a pass. This is also in that same area. This was a testing centre that we established so that visitors coming in could quickly have a rapid test and then go up and visit their family member. So this is just some of the examples of how we can how infrastructure can put a pandemic management much more in your favour. We've also been doing these scenario exercises. I won't go through this, but basically it runs from 10 a.m. to 6 p.m. and shows the movements, all the things that we can assess as a patient goes around the hospital. We published on this in 2016, so it's a nice little example. I recall they're very annoying at the time, but when the pandemic hit, we were really good at making sure patients could be assessed and moved around safely, and everyone was also obviously very practiced in PPE and modifying various areas. And as I mentioned, the Infectious Disease Act, look at the date where it was last revised, July 2003, straight after the last SARS. So they realised that there were many shortcomings from the original, and here's many of the things that the powers, and therefore when the pandemic hits, you don't have to negotiate these or debate these. They've been in place for a long time, and sometimes used for TB or suspect Ebola cases or whatever. And everyone in Singapore is very familiar with this act. These are all GOARN partners, of course, the Beijing, China CDC, Germany's Robert Koch Institution, US CDC, Public Health England, and one of the newest GOARN partners is the Singapore National Centre for Infectious Diseases. And these are very important even in peacetime because they're doing research, they're keeping the pressure on to maintain that pandemic preparedness. And of course, when the pandemic hits, then they're there to create guidelines and collate knowledge. So I think this has been a very important development. But again, you don't do this during a pandemic, you do it beforehand. The next phase is readiness. This is when you know something's happening and you're getting prepared on the basis that over the next month or two, your country could get hit. And this is just to point out how switched on our place was. I was written to on December 31st, 2019. Dale, you may already be on top of this, but wanted to know so that our institutions can react if it turns into something serious. I wrote back on January the 1st saying, yes, WHO is a buzz. We'll get more information in the next 48 hours. Probably just wait for now. But I said I'd go to the emergency department and just talk to them about triaging, looking out for people from Wuhan, things like that. So I went to the emergency department that morning and they said, yes, they'd already established a pre-triage. Everyone coming in was being assessed as to whether they'd had travelled to Wuhan in the last 2 weeks or whether they had respiratory symptoms. So while particularly in Western countries we're not doing enough through January, February and then March, I think Asia was very, very responsive and fearful of what was around the corner. So what do you do in those couple of months? Well, you look at what you know and you gear towards incoming information. You can establish a whole of government approach. It's not obviously going to be a health problem. All the hospitals, all the health sectors, and in fact all the non-health sectors need to look at their pandemic preparedness SOPs and go through various scenarios. What if a pregnant woman with COVID comes in? What are we going to do? All these types of things. Looking at establishing your testing, your isolation processes, how are you going to manage surge if you suddenly get need hundreds. All these types of things, and most importantly, to engage with the community and engage with healthcare workers. So this is a typical sort of whole of government approach. Obviously, all these things, I don't need to tell you, trade and industry, essential supplies, communications, security, manpower, education, finance and transport, with no planes flying. All these departments were getting impacted and they all needed a seat at the table as leaders discussed strategy and how we were going to maintain water, electricity, waste telecommunications while our hospitals were getting overwhelmed. This was a very important feature. And then it comes down to the actual how you would manage the outbreak response. And these are very typical pillars. Obviously, everyone thinks about case management, laboratory, epidemiology, contact tracing, the infection control needs within and without of within and as well as our systems, all the logistic needs, the pipelines, maintaining essential services. You can't have people dying of heart attacks because everyone's looking at COVID, and you don't want to stop routine vaccinations and cancer screening, for instance. So, but I think that obviously well-being and psychosocial support kept coming up, and risk communications is always critical. If the community is not buying in, then, and as we've seen in some countries, you're going to really struggle. On behalf of GOARN, we submitted this to Lancet during the pandemic, asking everyone to really get back to focusing on these pillars. And you'll all be aware that Singapore is very dependent on its migrant worker populations, and this is one such. This is the day it was locking down. This is a dormitory of 25,000. I'm standing in the middle of a courtyard, so these buildings are all around us. So there's 25,000 foreign workers here, with typically maybe 12 people in a room. So there's 10 of these buildings, 10 floors and 250 people on each floor. So it is high density living. But again, we found that applying these same pillars can be applied, and I won't go through all the little blue ones, but this is how you apply these pillars to any outbreak setting. And if you forget any of these, then they'll all suffer. We did find risk communications was an issue in the foreign worker dormitories. So we created a group called My Brother SG and engaged all sorts of groups that were pre-existing in the foreign worker dormitories. And we also engaged the foreign workers themselves to try and help get the messages out. We needed people. They were getting very concerned. They would all be marched down to have a test. And then the next day a bus would come and take 30 or 40 of them away, and they'd say, what's happening to those people? Are they being deported? So people obviously worry if they're not being kept in the loop. So this was really about explaining how they can make themselves safe and what the strategy was in place. And this was really quite successful as we engaged and got things in their own language. And this is one of our leaders that's actually talking to a group of ambassadors who could then go back and spread the word within the dormitory. And this actually attracted funding from WHO, so that this is a website that describes how this happened, and in fact how it could be applied to other large closed communities. But also on risk communications, we've done many things in Singapore, lots of webinars. The multi-ministry task force, as I say, this is representing 4 different ministries. The Prime Minister would come on about once a month, and when he spoke, everybody went quiet. He didn't, the timing was very good. If he's on every night, nobody cares. So he came for the profound speeches. These people are on every week. And then we've got some sort of nominated experts. This is Alex Cook and David Allen and Louisa and YY Teo, so lots of partnering to give information to the community in different ways. Many of you may know Gurmeet Singh, one of Singapore's most famous comedians, and they did a lot of good videos, which again people could relate to, quite humorous, but got the message through. And we also did regular cartoon comics. So communications was deliberately pitched in all sorts of ways There's also others with community leaders, Muslim leaders, things like that that would help get the messages through. So some of the interventions that happened, we've had mask mandates throughout, and they're still going now. Our largest informal social gathering is now gone up to 5 people at a restaurant or at your home. Larger MICE events are very controlled, but are coming on now. Working from home is very normal. Flexible working hours is acceptable. Telemedicine is very common. Maybe 5 or 10% of all consultations now are done virtually. Zoom, well, we all know that's become a normal way of life, and 2 years ago I wouldn't have been able to turn it on. Hospital support for communities and vice versa. Our hospitals went out to the foreign worker dormitories, and they went to many other places to provide medical services when they were locked down, and this was done fairly gladly. So this is in a dormitory with a whole lot of hospital staff. But on the other hand, this is Singapore Airlines cabin crew coming in to help out in the hospitals because they weren't flying. So they said, train us and we'll come and help look after patients. So this was good. And of course, the technology has flown along. You can just wave your phone as you walk into a building now, and that's registered. So this is, I guess, the other place where Singapore slipped up, apart from the foreign worker dormitories. As we rolled out the vaccine, you can see very good numbers down the bottom, that 94% of the eligible population is vaccinated, 85% of the total population. It's been about 700,000, or 21% of the total population have now received boosters. What I wanted to point out was this black line, which is the 70s and overs. They've actually come along to be the lowest vaccinated group, and they're the most vulnerable, obviously. And there are reasons for this. They're worried. They've received advice that, you know, not to get vaccinated, or a lot of them are very carefree anyway. They might just say, I'm old, I've got heart disease, I'll let nature take its course. But the point is, you could see this happening here. So back in June, July, we should have seen that it was starting to level off, whereas all the others have leveled off, or started to level off in the 70s and 80s, or in the 70s, whereas this was leveling off sort of below 60. So I think we could have recognised this. It wasn't expected, but it still has been a struggle, and obviously a lot of unvaccinated seniors are causing problems now. These are a couple of days old, but you can see how Singapore's pandemic has panned out. This is the foreign worker dormitory outbreak. When this was eventually curbed after 3 or 4 months, you can see there's a very low level. A lot of days of 1 community case, 5 community cases. We didn't rush to lock down everybody again because we were always wearing masks and limiting numbers. But it was in August that once we had more than 80% of the eligible vaccinated, we started easing restrictions, and we were a bit surprised that the number really took off. And we've had to go very slowly. We didn't have a freedom day. It was, let's allow people to go and eat in hawker stalls again, and let's allow travellers in. But suddenly we got this. But as you can see, this surge is now coming under control. In mid-August, we only had about 30 deaths. So, as you can imagine, with all the unvaccinated seniors, that has kicked along a lot. But still, we're looking at 10 to 15 a day, which is by international standards very small. These are the community cases by age, and you can see again back in mid-September we're 1,000 cases. 2 or 3 weeks later we're over 3,000 cases. So this is the surge, but you can see it's overall turning back down. And because of the high level of vaccination, this shouldn't be forgotten. It's, in fact, these are in the last 28 days. 84,000 or 98.7% are mild or asymptomatic cases. So we have to bear in mind that the case numbers and the severe disease are not what they were a year ago, and therefore we have to care a little bit less about the case numbers and focus more on what's happening in hospitals, because you can see that the deaths, which obviously increase with age, the fully vaccinated, which are these dark ones, are actually the vast minority of deaths. So I've said many times in the media, we should mandate this if we're going to mandate political view. So anyway, unvaccinated people are the vast majority of the deaths. So it was difficult to flick the switch. Singapore had throughout always admitted or at least supervised in hotels COVID positive cases. So when we said, no, you can now go home because it's a mild disease if you're vaccinated, people were still coming to hospital and we were getting into trouble. So we've had to invent various community treatment facilities. Our Formula One pit has had some tens of millions of dollars spent on it to convert it to a community treatment facility. So particularly the maybe young unvaccinated people are put there so we can monitor them, and we can provide oxygen and things at these places. But you can see now we've got most people recovering at home, but still a sizable number in community care facilities and treatment facilities. But nonetheless, I think today there's about 1,200 people still in hospital. Now, this you can see we've got 1,100 people in hospital. We've got 240 on oxygen, and these are the numbers in ICU, which is here on ventilator 40. So these are the numbers we need to watch, and I think there's a gradient down to ease restrictions more. And again, you can see that our capacity a month ago, this was about 300 ICU bed capacity. That's now gone to 430. So we're increasing the capacity. The blue is the ICU patients that are non-COVID, and these two green ones are the COVID cases. So the COVID cases in ICU are coming down. Empty beds are going up. So again, we're reassured that we're not going to get overwhelmed. So these are the ones we're looking at more than overall case numbers. This is one of my last slides. So the pink are the not fully vaccinated and the blue are the fully vaccinated. And what I want to show you is these are the people, these bottom two are the ones in ICU, and you can see there's more pink than blue. So there's more unvaccinated than vaccinated, and unvaccinated represents 6% of the eligible compared to 94% of the vaccinated eligible. So to think that 2/3 of the cases in ICU, and in fact 2/3 of the cases on oxygen, are coming from that 6% of unvaccinated people. So the point is that a small percentage of people can still be a large number that get sick and can stress your health system. So this is another thing we've learned, that the percentage doesn't matter. When there's still tens of thousands of people unvaccinated, you can't just have a freedom day. So on Singapore's way of exiting the pandemic, the series was that slowly, very, very slowly, very carefully, to get to the other side, and then we can mitigate along the way if we want. So the take-home messages from my view is that the whole cycle of preparedness, readiness, and response needs to be won. We have a strong intrinsic health and public health system, so that obviously helps. If you've got a frail system to start with, then you're going to struggle. The leadership and the organisation at the highest level is critical, and we've seen failings of that in many other countries. And strategically doing the risk communications, community engagement in a diverse, nimble, responsive, multimedia way is critical. We fell short of expectations, I think, in the migrant worker dormitories and in vaccination of seniors. It's important to closely adhere to the science, which I've heard over the last couple of speeches, quite nice. But you also have to have your own data internally. And again, this cautious exit. So just to bring it back to one of the original slides in the brief, which was about recovery, I think Singapore's management of this means that we have less recovery to do than many other places. There is still recovery, of course. Other places will have to be incorporating preparedness into their recovery and looking at their Infectious Disease Act, looking at their infrastructure, looking at their human resources and starting to develop this. But there's going to be a lot of mental health damage, especially those who are grieved and those whose livelihoods have been damaged. Need to look at the overall business impact, and there'll be a lot of recovery going on there. There's a lot of, in hospitals, they've got a lot of elective work to catch up on, including elective surgery, cancer screening, people who haven't had their hip replacement for the last year, so they can't walk. We need to do a lot of catching up on all this. We need to improve the context of migrant workers to prevent future events. And we need to stay up with the science, which is continuing to evolve in terms of treatments and the role of boosters. I think this pandemic, in a way, is for some countries is a bullet dodged. If this really did have a disease X type mortality, we could have seen even a worse situation, and therefore I think future scenarios need to look at a higher mortality, particularly in young people, and how we would have managed that. So thank you for listening to me.
Thank you very much, Professor Dale. I think you really bring the full cycle to all this, and I really like how you saying the first thing that outbreak is not just about response. I think it really grounds us to, or even step back to look at a more complete picture. And the word crisis, I think people have seen so many quotation around crisis, opportunities, and all those. So I think that's a really nice way to bring things together. So now I would like to continue to the discussion period, where we have already a few questions lining up for the speaker. So I have Dr. Imran, Professor Echo, Professor Dale all with me. So this is great. So the first question that we were asked was specifically for Dr. Imran. So the question is, if we have been vaccinated for first and second dose with Sinovac, and then we need vaccine booster with Moderna, but then if we have been vaccinated with Moderna, is there really necessary to add more vaccine booster, as we know that some country like United Arab or Saudi has opened a permit on the condition that that people might be vaccinated with the third booster vaccine, even though they have been vaccinated with Sinovac. Could you please comment on that?
Yeah, thank you, Prof. So about this question, I think it's related to the Umrah policy, Umrah or Hajj policy from Saudi Arabia. So what I understand now, what I informed now, that's true that in Saudi Arabia, when the Umrah from Indonesia came to Saudi Arabia, so the Saudi Arabia authority wants to have one booster vaccine outside the Sinovac. So I think it related to the policy in Saudi Arabia that the vaccine that already approved in Saudi Arabia is limited. Yeah. So what I understand, AstraZeneca, Moderna, Pfizer is already approved, but Sinovac is not yet approved. Yeah, not yet approved in the Saudi Arabia. So that's why Saudi Arabia authorities need to have one more vaccine booster when the people from Indonesia are already have vaccinated, complete vaccinated with the Sinovac, because they need to, Saudi Arabia authority need more, what we call, more convinced that the other brand outside Sinovac need to be injected to the Umrah, Jemaah Umrah from Indonesia. I think that related with this regulation, not about the what we call the efficacy of the vaccination. Maybe Dr. Dale can have more information about the efficacy about the vaccine in the COVID. But what I understand, yesterday I read the what we call the articles. So Sinovac plus Pfizer or Moderna, the efficacy is around 96%. But Sinovac, 3 doses, yeah, it's around 74%. So it means that, yeah, they need more convinced about the booster one. I think that's my answer, Prof. Thank you.
Thank you, Dr. Imran. Professor Dale, Dr. Imran referred to you slightly. Anything to comment?
Yeah, I think we've still got, yeah, thanks for that. Very, very difficult question. Firstly, we've got a lot to learn about the mixing of vaccines. We simply don't know. I think there's some reasonable evidence coming out that different vaccines being used can be superior to having the same one each time. But we really don't know. That there's not enough evidence. There are studies being done, and of course there's so many vaccines now. There's so many different combinations and permutations you can have. What I would say, however, though, is that we're not seeing waning of vaccine efficacy against severe disease, ICU admissions, and death. And the reason the boosters are being brought in is largely to try and control transmission. And that, as Imran suggested, that's the one that does wane. The mild and asymptomatic disease, that does seem to be waning with time. So you could argue that booster vaccines to ease transmission would help, but why are we trying to ease transmission? It's because we don't want the unvaccinated to get severe and dangerous disease. So actually, and this might be a little bit controversial, but we're largely giving boosters to people that will take the vaccine to help the people that won't take the vaccine. And this irks me a little bit, although I can see in government. So I would definitely give boosters to those at risk, to the over 60s and those with comorbidities. They're the ones that will mostly benefit. But to give it to otherwise well 30-year-olds just to prevent transmission, I would much rather see this vaccine going to countries that don't have vaccine to get the unvaccinated senior and healthcare worker in other countries vaccinated.
Thank you very much. I think that certainly could open up another line of question as well. But before I continue on that note, because I do want to get to the question that were sent to us before. So the next question is for Professor Echo. It's a question from Professor Adik. So she asks that there is an evolving consensus on testing effectiveness. One is about the validity of negative testing and how long a negative test may be considered valid.
Yes, okay, thanks, Prof. Rudy. So this is very difficult actually to generalize the validity of negative testing. It depends on many factors. Okay, a few of them, for example, the travel history, the health risk, behavior history, and then the vaccination status. For example, if the people stay in the non-vaccinated and high-risk region, okay, 1 day validity shall be applied. But if, okay, in the low-risk region, yeah, for example, but still having COVID a little bit, 3 days validity can be applied. But in the very low risk, it means okay, almost 0 case, then more than that, 7 days validity, okay, can be applied. So we will see, okay, the cases. But okay, my suggestion in average should be like 3 days validity shall be applied. Okay, my answer.
I know Professor Adik is here. For Professor Adik, any follow-up? You on mute. Yeah. Sorry, Professor Adik, you on mute. You got to unmute.
Oh yeah, thank you very much, Professor Eko, for the answer. I know that is a very dilemmatic, actually.
Yeah, all right.
Thank you.
Welcome.
Okay, yeah. The next question we have is for Professor Dell. The question is how Singapore government encourage their citizens, especially the contacts of confirmed cases, to conduct COVID testing. Is there any sanction or law enforcement for those who reject this? In Indonesia, the rejection to conduct COVID testing faced by many of tracers. Please.
Is there a law? I think from, we're going back now. So we don't do as much contact tracing now. It's with 3,000 cases a day, because the impact of contact tracing basically means you're going to be quarantining those people. And if you're having 3,000 cases a day and you've got 20 contacts per person, then that's 60,000 people per day you're quarantining. And then after 10 days, you've got 600,000 people in quarantine. That's basically called a lockdown. So because everyone's in quarantine. So we don't do that anymore because we accept that the vaccine has to be allowed to do its job and prevent severe disease. So the contact tracing now is mostly limited to household contacts. So we would ask that those people stay home. This can be, I'm not sure of the exact phase we're at now, but certainly contacts could be done in a supervised way. For instance, in a hotel, especially if they lived in like a hostel or a boarding house or something like that. But if they could stay at home, they're allowed to stay at home. Sometimes we would put Bluetooth bracelets on people to make sure with some GPS location, largely as a deterrent. If you're in quarantine because you're a contact, we don't want you to leave your home. Not because we're tracking you and we want to punish you, but there certainly is it is a criminal offence. If you're required to stay home, you can get up to 6 months jail potentially. And there's certainly some people got heavy fines for breaching their quarantine. But really the way to do it is through community engagement again. And the vast majority, and I think this is the case across the world actually, most people bought into it, even in countries where you see marching along the streets and things like that. There's still a minority of people. I think most people bought into their obligation as a citizen to help fight COVID. So yeah, the answer to the question is engaging the community, getting the buy-in, using the various techniques. But sure, there are laws to back it up.
Thank you for that. So perhaps on that note, I could build on one of the concept, one of the topic that came up in all the speaker presentation and even in the last couple of questions, the concept of, or the topic of vaccine hesitancy. We talk a lot about the vaccine and how we are relying on it as one of the tools to help control this pandemic. As we all know, vaccine hesitancy is very real. It's considered one of the top 10 global health threats even before COVID-19 vaccine. So may I ask all the speaker to comment on, in your context or even in our region, like what are some of the things that organization could do or country government could do to actually address this and trying to get more people vaccinated? Anyone would like to go first?
Yeah, Prof. Rudy, maybe I want to make the comment first. So
yes,
in Indonesia nowadays is around maybe 62% of the target had already first dose of vaccination. So nowadays maybe in Indonesia already reached the hard rock one. I mean that what is the hard rock? Hard rock is the one who live in the remote area and also the one who live in the urban, but they still have hesitancy for this one. So I think we should do both. We should expand our outreach vaccination in the remote area, because like what I present, we have a lot of island in Indonesia, and the other way, we should have maybe more what we call various campaign, especially for those who live in not in the remote area, but still have hesitancy for this one. So we should engage with the religious leader and also engage with the what we call politicians sometimes to reach the people that still has hesitancy for the vaccine, COVID vaccine. I think that's my comment, Prof. Rudy. Thank you.
Thank you, Dr. Imran. Professor Eko?
Yes. Actually, it depends on the target. I mean, if the targeting for the vaccine is the elderly, then we need to have approach for how the elderly normally accept our idea, basically. And for young is also we need to approach according to how they accept our idea or our program. Basically, this is the basic idea. So and then we need to promote, to also give the evidence, testimony, and beside that also we need to show the comfortability of the vaccinations and so on. I think for me it's more to personalize, or not really personalize, but it's depend on which group we want to target, and then we need to define program for them. We can generalize the program for the acceleration of the vaccinations process, basically. So this is from mine.
Thank you. And Professor Dale?
Yeah, thanks. This is it's like every question could become a talk. So I think when it comes to vaccine hesitancy, there is a spectrum, right? There's your true anti-vaxxers, and then there's through to people that are just tired. Maybe they've got information overload. Maybe they're just sick of it and want to be left alone. They're not true anti-vaxxers, and I think they can still be, if you get the right information to them by the right person, they're still salvageable. But the anti-vaxxers, they're kind of an interesting science in themselves. If you're aware of the Dunning-Kruger effect, it's the people that have the most conviction in their beliefs are the ones that are the most ignorant, actually. and they hang on to this belief, and there are reasons for it. They've suddenly got a voice, they've got a status, they've got some power, they've got a whole lot of followers on Twitter or whatever, and this is their aim. They're actually not trying to hurt people. They're thinking, well, I've got a view that connects with people, so I have a responsibility to continue on this way. So I think there's lots of reasons to look through this. In Singapore, we've had there's lots of misinformation. Of course, everyone's got those sites and statements, but while Singapore has monitored it, they really haven't stepped in significantly, thinking that these are a minority. They'll run their course, and we'll fight it with our positive strategies of good information from good sources, from trusted people. And that was that slide I showed you in community engagement. So that's why we've had that very good pickup in all but the people that deserve it the most. And now we find ourselves with a long line list of all the over 60 unvaccinated people, and there are teams going door knocking, literally spending half an hour per person to take them through the information in their language, and the answers that they're getting are, I'm old already, I don't see any point, I have all these other medical problems and the vaccine could hurt me, or even my children said not to do it. My doctor told me last year I shouldn't bother with the vaccine, or 6 months ago I shouldn't bother with the vaccine, and that's because Singapore had no COVID at the time. So that advice lives on, even though clearly it's a different epidemiologic setting now. So I think it's a good question, but it's complicated.
Thank you. No, I think all of you have highlighted all the key part. We know it's certainly remain a topic that all countries are working to address together. So any input that you just share, I think that is quite informative as well. I have another question for Professor Dale. And the question is, you mentioned in the last slide with the cycle diagram, could you explain more what we should do more in preparedness block during this pandemic situation to face the end of the years on holiday season?
Okay, you've put another layer on the cycle. That cycle is supposed to be like a decade, if you like. If there's going to be another pandemic in 10 years, then preparedness would be like 8 years of that to prepare. But this is another layer, and if we're talking about what we should do to prepare for this ongoing situation, I would very much say it's surge capacity. As hospitals fill up in whatever country, what are you going to do? And I think we're already seeing Europe struggle with that. I honestly think Europe's been taken by surprise. 2 years into the pandemic, they're still getting surprised because they're locking down again. And you think, why haven't you over the last year gone through a scenario which meant when we get our hospitals getting overwhelmed, what can we do? What can we do to prevent that, and what can we do to mitigate against it when it happens? So when it happens, what's your surge capacity? So now you could be preparing for surge. What are you going to do if suddenly we get another wave, and we see what we saw in Indonesia a few months ago? Are we ready, or could that happen again? So that'd be one level of preparedness. And to mitigate against that would be maintaining the restrictions. I'm not sure of what the situation is in Indonesia currently, but I would not be supportive if you'd had the Freedom Day approach of many other countries, which is take off your masks and have large gatherings and pretend the pandemic's over, because it's not. You've still got a lot of people unvaccinated, and they can put a huge burden on your health system. So that's what I would say. I'd be talking about what restrictions are needed still, because the pandemic's not over, even though we want it to be. and how do you, how's your surge capacity developed so that you don't get overwhelmed?
Thank you. No, certainly if there's no quick answer to any of these questions. If I maybe perhaps can continue this discussion, because as I think all of you have highlighted that there always, in this type of situation of the pandemic, there are more than one factor. But when we think about healthcare, oftentimes we think about resources that we have, right? And certain resources are more limited than others. So I'm referring to things like critical care resources. So refer back to the earlier day of pandemic, Europe certainly got surprised when they hit with the limited resources for ventilators and ICU beds, among many others. So perhaps I could ask Dr. Imran that you mentioned about the use of oxygen as like for certain group of patients. So in Indonesia, are there separate guidelines for these resources or even ICU bed compared to other resources that may be, not to say that healthcare resources are not limited. We all know that healthcare resources are limited, but like these are perhaps more limited than others. Like, are there separate guidelines for this type of critical care resources? Question for you. For Professor Echo, I think perhaps from your perspective, should there be, because there were discussion that, you know, when like there should be protocol in place when people, how, so instead of making the decision on like rely on one doctor, there should be a protocol in place to say, like if there are 10 patients but only one ICU bed with ventilator, who should be the one who get that? Like, what should there be a protocol to help with that process? And to come back to you, perhaps Professor Dale, it would be great if you can share your comment on that. But a question that came to mind around resources is, when I see your presentation is right now, and that happened in Thailand too, we have a lot of field hospital, a lot of location that being like readapt, expanded, converted into field hospital and even to the equivalent of ICU bed. We hope that eventually we will no longer need them. So what do we do after with all these additional resources? So does it mean we now going to have more ICU bed than we need, or like any thought on those? But perhaps I'll go in the order. Dr. Imran first. Thank you.
Yeah, thank you, Prof. Farudi. It's very challenging questions here. So yes, during COVID-19, we monitored the bed occupancy ratio, especially for the ICU, and we monitored very what we call closely, for the area that that they has a high burden. For example, like in the second phase, like Jakarta and near Jakarta, and also East Java and several provinces. So I think we have around 15 provinces that we have to monitor the bed occupancy ratio, especially for the ICU and also for the oxygen. So with this close monitoring, we like we not only monitor but also we instruct the province and also district that they should change or transfer for the what we call the inpatient room to ICU, for example, because Indonesia has a decentralization and health is also decentralized. So in the normal way, the local government take command for the health. But in this pandemic, during the pandemic, especially for the second wave, central government has authority has direct comment to the several districts and several provinces to make corrective action for the health facilities to do the the important measures about that one. I hope that answer the questions, Prof. Pandubi.
Yes, no, thank you. I think that's very informative. Thank you, Dr. Imran. Professor Eko?
Yes, I think there shall be a protocol in place. Yeah, because in the critical situation, yeah, we need to have the emergency protocol basically. So, and then this must be depend on the risk-benefit analysis, cost-risk-benefit analysis also. For example, people that having the highest risk, must be treated first, for example, and then if they have the same risk, then we need to see the benefit. Then whether for example the children or the elderly, for example, then we need to the children maybe. So and then we need to see also the cost, whether if we treat this how much is the cost. If the cost is too high, then we cannot cover, then better to have lower cost, but for many more people, for example. So I think there must be some protocol that related to some risk that I just mentioned just now. So I think so. Prof. Panduri.
Thank you, Professor Eko, and back to you, Professor Dell.
So the case mix of the critically unwell people is changing into perhaps more complex cases because of treatments and because of vaccines. So it's quite different to a year ago, where a middle-aged person with no comorbidities could end up in ICU. Now that middle-aged person with no comorbidities who's vaccinated is unlikely to even get severely ill. And furthermore, as we understand better the role of, steroids are clear, monoclonal antibodies are increasingly clear, and antiviral therapies. And for instance, if we can get, the newer drugs like molnupiravir, if they develop in a way that we expect, then it could be a lot less people are requiring ICU. So I think the upstream measures are going to have a bigger impact on ICU. Of course, you'll always need ICUs because there'll be people that slip through. But we already know if you look at, so I showed you the Singapore data, the vast majority of people that need ICU are the unvaccinated. So as that unvaccinated number continues to fall, indeed, as many of these people get natural infections, so they get immunity naturally, then I think the pressure on ICU will accordingly fall as well. So, and as Prof. Eko says, it's the people that do come through may be the ones that are very frail, the ones that are got a lot of comorbidities, and they may be the ones that say, look, they failed monoclonal antibodies and steroids and antivirals. This group doesn't survive ICU, so there's little point. So we're going to learn a lot more about the speak quiet in the future compared to those in the past.
Thank you. I think we approaching the final stage. Perhaps before I hand over back to the master of the ceremony, I could ask if all the speaker has any final take-home, final message that you would like to share, as many countries are now opening up, while some in farther away have been going to lockdown. I think countries in this region, including Thailand, are opening up. Any take-home message you like to share with people as individual in the community or the organization as well? Dr. Imran?
Yeah, Prof. If you allowed me, maybe I have two things here. First, about the take-home message, and other, I want to ask very simple questions for Prof. Eko. Is it possible?
Yes, please.
Yeah.
Okay.
Of course.
Yeah. So I think for the take-home message is we should prepare for the what they call new era. I think this new era need more adjustment about us for us to do the same activities but different way. Yeah, same activities but different way. So I think we should prepare for that one, and we should be ready for the consequences of the new normal. And the question for Prof. Eko, yeah, regarding with the what they call the remarks from the Ministry of Health. So I think this webinar is one of the platform that we can bring to the G20, because Indonesia in 2021 is the presidency of the G20. And one of the message of our minister mentioned that how we can develop the international health protocol for travelers, because if we like now that every country has the different protocols, it will be difficult to what we call to move for the economic level. So maybe Prof. Eko can have something that to take home message also about that one. Thank you, Prof. Parode.
Yes, Prof. Eko, please.
Yes. So thanks, okay, Dr. Imran. So from our study, I think, just now I propose, our group proposing the new health protocol for international traveling. This is something that we can bring to the G20 meetings. But important there is one is the emphasis on the vaccinations. That vaccinations effectiveness also reduced. And then the second message basically is the test. The rapid test shall be, I think, implement more than currently, for example. And then is also the utilization of the digital technology, the mobile apps that we need to also discuss with more and more countries to have the similar platform, similar criteria. Only will be depend on the region, depend on the people behavior there, depend on the health risk, so that it's general platform but personalized. It cannot be like based on the country. Even for example, in Indonesia itself, if we see Jakarta is, I think it's more than 80% vaccinated, for example. So we need to treat differently with the province which is still other 50, for example, vaccinations. So and also people that already vaccinated more than 1 year, we need also to treat differently. I think we need to develop after this if you agree, we can have some discussion more on the calculations and how we able to develop some general formula or platform, so that we can implement, and then we can propose, and for the future we can implement that stay not just for few months. But I think the current protocol will just stay for few months. After that, I think will be disappears. For us, important is to have the long-term protocol, health protocol that can stay for many years, basically 3, 5, and so on years. But it's really general platform, general a lot of criteria, but personalized and depend on the situation. And this is only work if we use the digital technology. So I think this is my last message.
Thank you, bro.
Yeah.
Thank you. So I think that's great word. So maybe I'll go quickly to Professor Dell to see if you have any final word to share. Yeah.
Yeah, I'm just worried about my video connection, so that's why I turned my video off. But I'll try. Listen, I'm over in Geneva at the moment, and in general, there's a sense that I guess Asia, especially East Asia, has done particularly well during the pandemic. There's been a strong reliance on border controls, and in some countries, I think Malaysia is one where, when those borders were eventually breached, there was a lot of problems, and same with Thailand and Vietnam and other places. So I hope the rest of the world learns from Asia. They're generally reluctant to learn from this side of the world. It's usually the other way around. I hope they learn, but also I hope Asia takes this lesson and so that next pandemic we deal with it better. We have stronger public health systems, stronger health systems, and stronger surge capacity. I think we're never going to get it if we don't get it in the wake of the pandemic. So that's what I hope for in the future.
Thank you very much. So I think at this point, that's the end for our panel too. Please join me to thank all the speakers, Dr. Imran, Professor Echo, and Professor Dell. Thank you again, everyone, for joining us this afternoon. And with that, I would like to send the event back to the organizing team. Ms. Devi, back to you.
For an amazing facilitation. Ladies and gentlemen, we are almost at the end of the webinar. But before that, on behalf of the organizing committee, I would like to thank you, His Excellency Minister of Health and Madam Regional Director, for their kind remarks, all moderators and speakers, as well as all participants that make this webinar a success. I believe this webinar contributes to our collective effort in strengthening health security, particularly in the regional level. This program is collaboration between the Ministry of Health Republic of Indonesia, World Health Organization, Association of Southeast Asian Nations, and Institute of Transformative Technology and Policy of COVID-19 Response and Recovery Plan in Southeast Asia. I, Dewi Sartika, sign off and hope to see you soon in the next webinar. Goodbye and have a pleasant day.